from Dhanbad have joined. He is general and lab surgeon at his clinic working in Dhanbad, and we all know him very well. He's a very busy surgeon in Dhanbad too. Welcome, sir. Welcome you all.
Thank you. Thanks a lot.
Dr. Harsh. He has also not joined yet. Probably he will join in. So for today's session, we will give 7 minutes for presentation and 2 minutes for discussion. So our first speaker is Dr. Rashmi. Good morning, Rashmi. And now open your Q&A and start your presentation. Yes. You'll get 7 minutes and 2 minutes for discussion.
Yes, ma'am. Can I start? Hello.
Someone needs to mute. There is a background noise. Omega, ask everybody else who is not speaking to mute.
Rashmi, start your presentation.
Okay. Good morning, everyone. I'm Dr. Rashmi Kullu, and my guide is Professor Dr. Vinay Pratap. I'll be presenting lipase to amylase ratio. Can it be used to differentiate acute alcohol-induced pancreatitis and from acute biliary pancreatitis? Acute pancreatitis is one of the most common diseases with which a patient presents to the emergency setting with acute pain abdomen, and it ranges from mild self-limiting episodes to severe necrotizing pancreatitis. The etiologies of acute pancreatitis are multiple, but the commonest are alcohol and biliary tract diseases. Amylase and lipase are the two main enzymes that are used for the detection of episodes of acute pancreatitis. Three times the increase is pathognomic of acute pancreatitis. There have been several studies that suggest that lipase to amylase ratio is an important tool to distinguish biliary tract disease-induced pancreatitis from alcohol-induced pancreatitis. For this study, we studied patients who presented to the emergency from April 2019 to April 2020. This was a retrospective study, and we studied 55 patients, 11 of whom were female and 44 were male. And the patients were diagnosed based on lipase and amylase levels, and as well as CT scans and MRCP when needed. The normal value of serum amylase was taken to be 20 to 96 international units per liter, and that of serum lipase was taken to be 3 to 43 units per liter. We found in our study that most of the patients were males, with 44 patients out of 55 patients being males, and females only made up 11. And the youngest of the patients was aged 12 years old, who had presented with gallstone-induced pancreatitis. It was seen that in the average age of presentation was lower in alcoholic group than in the biliary tract group. The alcoholic group, the average age was 36.28 plus minus 13.39 years, and that of biliary tract disease, it was 42.8 plus minus 14.54 years. The females constituted only 20% of the cases, while the males made up 80%. All the females had presented with gallstone-induced pancreatitis, and the majority of the males were presenting with alcohol-induced pancreatitis. The serum amylase and lipase of the two groups, the average serum amylase and lipase of the two groups are presented in this table. And as we can see, the difference between them was not very significant, as the p-value was only 0.725. Now we come to the discussion. Serum lipase and amylase are the two most easily available and widely used diagnostic techniques that are used for the diagnosis of acute pancreatitis. It also serves as the primary test in the emergency setting. In our setting, it was found that most of the patients with pain abdomen presented with acute pancreatitis. Most of the patients in our study were males, constituting 80% of the cases, and females made up only 20%. Only patients presenting within 72 hours of symptom onset were included in the study because the levels of serum lipase peaks at 72 hours after onset and then it falls. The average age of presentation in acute alcoholic pancreatitis was 35, and that in the acute gallstone-induced pancreatitis group was 43.5. Hence, the average age at presentation is lower in the alcoholic group. The males made up most of the cases of acute alcoholic pancreatitis with 79.5%, and gallstone was the cause of acute pancreatitis in all female patients in the study. This was also similar to the findings in the previous studies that was conducted. The serum lipase level in alcoholic group was 765.8 plus minus 722.7 units per liter, and that of amylase was 920 plus minus 1071.9 units per liter. And this was not, and that in the gallstone induced group was 936.5 plus minus 993.8, and that of lipase was 1935.05 plus minus 4818.07 units per liter, but the difference was not statistically significant. This was similar to the findings by Gamaste, VV et al. The lipase to amylase ratio ranged from 1.41 plus minus 4.86 in the alcoholic group, and in the gallstone group it was 1.29 plus minus 1.70. This too was found to be insignificant with a p-value of 0.07. This is a graph that shows the serum amylase and lipase levels in both the groups, with the red lines representing the serum amylase level in the biliary tract group, and the blue lines representing the serum amylase levels in the alcoholic group. This is a graph that represents the serum lipase level in the alcoholic group versus the biliary tract group, and the red lines represent the serum lipase level in the biliary tract group, and the blue line in the alcoholic group. This was similar to the findings by some of the previous studies by Mimos, Oliver et al. And Harish Casey et al. Studies by Devnath A. et al. And Pacheco et al. Suggest that... Pardon?
Only 30 seconds left. Finish fast.
Okay. Suggests that the amylase to lipase ratio in the two groups were found to be insignificant. My conclusion, through the study, we came to the conclusion that lipase to amylase ratio is not a very significant tool to differentiate the etiology of the two diseases. Thank you.
Okay, Rashmi has finished on time. And Dr. Haq and Dr. Parvez has also joined. Welcome, sir.
Thank you.
Yes, sir. Now the stage is open for discussion. Judges are requested to ask questions from Dr. Rashmi if they want to.
What was your take-home message?
So, in many of the studies, lipase to amylase ratio was found to be a useful tool in knowing the etiology of the disease. But in my study, it was found that it was not very useful. And since lipase to amylase are the primary diagnostic techniques that we use, so I thought it would be useful. But my study proved that it was not very useful in knowing the etiology.
Yeah, not useful to differentiate.
Yes, sir.
Okay. Thank you.
Thank you, Rashmi. It's a nice presentation. If anybody can ask a question.
Satish sir probably want to ask something, but sir, please unmute yourself. Parvez sir, welcome sir. Please unmute yourself before speaking.
Yeah, okay.
Yes sir. Now you're audible.
Yeah.
Want to ask anything?
No, it's okay. No.
Okay. Thank you, Dr. Rashmi. You have finished in time. Very good.
Thank you, ma'am.
Our next speaker is Dr. Saurabh. Saurabh, are you there?
Yes, ma'am, I am there.
Yes, start your PPT. Start your presentation. Okay. Open your PPT and start screen share.
Okay, ma'am. Am I audible?
Yes, you are audible. Start.
A very warm good morning to my respected judges, my teachers, and my colleagues. I, Saurav Kumar Singh, JR at the Department of General Surgery, RIMS, Ranchi, is going to present you about the study of pancreatic duct in pancreatitis using MRCP. Before commencing, I would like to acknowledge the constant support and valuable inputs by my guide, Professor Dr. R.G. Bakla sir, throughout the study. Special mention of Dr. Professor C.P. Sinha sir, Professor Dr. Pankaj Bodra sir, and Professor Dr. Mrityunjay Mindu sir for their positive criticism throughout this study. Introduction. Acute pancreatitis is defined as the acute inflammation of pancreatic gland and the surrounding tissues, and clinically it is defined as an acute condition presenting with upper abdominal pain, a threefold rise in serum lipase and amylase, and presence of characteristic imaging findings on contrast enhanced CT scan. Whereas chronic pancreatitis is defined as a progressive inflammatory disease in which there is irreversible destruction of the parenchyma and is characterized by severe pain along with both exocrinal as well as endocrinal insufficiency. Whatever be the pathophysiology of the pancreatitis, whatever be the cause of pancreatitis, the pathophysiology involves acinar cell injury leading to interstitial inflammation and edema, proteolysis, fat necrosis, and hemorrhage. The patient of acute pancreatitis presents with acute severe upper abdominal pain with or without radiation to back, nausea, and vomiting. Pain is usually constant and refractory to usual doses of analgesia and occasionally gets relieved by leaning forward. In chronic pancreatitis, apart from above mentioned symptoms, there is also features of exocrinal and endocrinal insufficiency like diabetes, weight loss, and steatorrhea. This study was a prospective type of study comparing the clinical severity of the disease with the findings of MRCP in patients presenting with pancreatitis at the emergency department at RIMS Ranchi. A total of 100 patients were evaluated between the time period of December 2018 to October 2019. Evaluation through USG and CECT was also done for these patients. The following table shows MRCP finding of pancreatic duct. It can be seen that dilatation of the main pancreatic duct was found in 19 patients. Disruption of the main pancreatic was found in 5 patients, whereas stenosis, pseudocyst formation, MPD calculi, CBD calculi was found in 8, 14, 12, and 32 patients respectively. The following graph shows MRCP findings in the relation of main pancreatic duct. Here we can clearly see that the dilated MPD clearly tops the chart, followed by CBD calculi and pseudocyst formation. The following MRCP image shows the normal anatomy of the pancreatic duct and common bile duct. The image on the right shows a calculus in the distal CBD. Here, left MRCP image shows dilated main pancreatic duct, and right MRCP image shows stenosis of the main pancreatic duct at the two sides. Now comparing these studies with CE-CT finding, we get main pancreatic duct dilatation in 7 patients, main pancreatic duct disruption in 2 patients, and CBD calculi in 32 patients. Now comparing the MRCP findings and CE-CT findings side by side, here we can clearly see that the sensitivity, specificity, and positive predictive value of MRCP is greater than CE-CT. In 2015, Raju Sharma et al. At RAIMS, Delhi, studied the efficacy of MRCP in diagnosing the ductal changes in comparison to CE-CT scan. They found in their studies in the favor of MRCP. Also, in the study of Soto et al. In 1996 and Moll Craig in 1993, concluded that MRCP has emerged helpful in respect to determine the presence of level and extent of pancreatic duct obstruction in most of the patients than ERCP. In my study, MRCP have diagnosed all the changes in main pancreatic duct in all the cases, including dilatation, disruption, and stenosis. Also in this study, the sensitivity of MRCP in diagnosing these ductal changes was found to be 95% and specificity to 100%. The positive predictive value and the negative predictive value in MRCP is found to be 100% and 98.55% respectively. Now to conclude, contrast enhanced CT scan was found very accurate in detailing of pancreatic necrosis, but its limitations included deranged RFT, and it failed to detect the ductal changes in 21 cases. Hence, it failed to accurately identify the main pancreatic duct dilatation, disruption, and stenosis, which was confirmed by MRCP. Hence, it is found that MRCP have a very effective and diagnostic accuracy in detecting the ductal changes, even better than CE-CT. These are my references. Thank you.
Thank you, Dr. Saurabh. We have finished in time.
Oh, yes, ma'am.
Yeah, Saurabh, this is Dr.
Yes,
It's a nice presentation. What is your take-home message?
The take-home message is for diagnosing the etiology of the cause of the pancreatitis. MRCP is better than CE-CT scan, sir.
You want to suggest that all patients of acute pancreatitis should undergo MRCP rather than CT scan?
No, sir. CT scan is good at diagnosing the pancreatic necrosis and collection. But when there is doubt about the etiology of the pancreatitis, then MRCP is better, sir.
What will be the indication then for MRCP?
A patient with pancreatitis, but we are not getting any stone or any cause. Yeah. In fact, alcohol is also history of alcoholism is also not present, and we are not able to find stones in the CBD or the distal CBD. Then we can use MRCP to further clearly define the etiology of the pancreatitis.
But it should not be routine for everyone.
So that yes, sir, it should not be the routine for everyone. But
where you are not able to find a particular, yeah.
Yes,
okay.
Sir.
Thank you. Thank you.
Sir.
So any other judges want to ask something?
It's okay. Good, Saurabh.
Thank you, sir.
Okay, thank you, Dr. Saurabh.
Hello, here is Dr. I'm Dr. Zaulak.
Yes, sir. Welcome, sir.
Just one question to Dr. Saurabh.
Yes, sir.
What are the indication of MRCP and ERCP in a case of pancreatitis? In a case of pancreatitis,
Sir,
when you will go for MRCP and when you will go for ERCP?
In CE-CT finding, if we are able to delineate the cause, that is, if in CE-CT we get the presence of stone in the distal CBD or at the ampulla, then ERCP is better for diagnostic, for interventional approach. But where there is doubt about the presence of stone in the CBD, then MRCP is a better option, sir.
Okay, thank you.
Thank you, sir.
Mute कर.
Thank you, Dr. Saurabh. Now our next speaker, Dr. Ajay. Ajay, unmute yourself. First, unmute yourself. You may start. First, unmute yourself and then start speaking. Start your presentation.
Good morning, sir. Today I will present my topic, incidence of hypocalcemia after total thyroidectomy, an observational study. One of the most frequent complications of thyroid surgery is post-operative hypocalcemia due to transient or permanent post-operative hypoparathyroidism, mainly due to compromise of vascularization of parathyroid gland. The primary cause of the hypocalcemia is secondary hypoparathyroidism. Hypocalcemia can be asymptomatic, particularly calcium level are only mildly reduced, or symptomatic with typical manifestations such as Wostek sign, Trozier sign, muscle spasm, perioral and peripheral paresthesia, severe neurological manifestation, if not treated adequately. Temporary hypocalcemia occur in 50 to 68% post-operative patient, while permanent hypocalcemia occur in 1.3 to 3% of post-operative patients. Temporary hypocalcemia defined by various authors as a post-operative decrease in calcium lasting for 6 to 12 months, while permanent hypocalcemia lasting for more than 12 months. Although the diverse cause of hypocalcemia include excessive discharge of calcium in urine due to surgical stress, hungry bone syndrome, due to hyperthyroidism or hypercalcitonemia and vitamin D deficiency. But most important cause include physical damage to the all four parathyroid gland. Production of parathyroid hormone play an indispensable role regulating serum calcium, increasing calcium level in body by increasing renal absorption of calcium, bone reabsorption, and activation of calcidiol to stimulate intestinal calcium absorption. All this by means of parathyroid hormone receptor coupled to G protein present in this tissue. Thus, any injury parathyroid gland lead to reduction or loss of their function will generate a reduction in serum calcium, which when severe can be life-threatening or lesser extent, affect importantly the quality of life of the patient and increase the day in hospital care. Aim of this study. This study to determine the incidence of hypocalcemia and assess the importance of intraoperative identification of parathyroid gland during thyroid surgery in the prevention of complications. This study was conducted in RIMS from February to March 20. Inclusion criteria of that study: age above 16 years, undergoing total thyroidectomy for both benign and malignant. Exclusion criteria of this study: previous hemithyroidectomy, lobectomy, resection of thyroid gland, and diagnosed pathology of parathyroid gland, previous neck surgery. The detailed history and clinical examination of all patients were done. The recent laboratory investigation like blood investigation, total serum calcium, ionized serum calcium, serum albumin, parathyroid hormone, 25D hydroxy vitamin D, thyroid function, ultrasound neck, and FNC. Post-operative hypocalcemia are defined as the serum total calcium less than 8 mg per deciliter within 24 to 72 hours after total thyroidectomy. Patients were observed in the ward for signs and symptoms of hypocalcemia such as Wostek and Trozier, perioral numbness, tingling, and muscle spasm. Patients who were found to clinical hypocalcemia were given slow intravenous infusion of 10 ml of 10% calcium gluconate. Patients were subsequently assessed for clinical sign of hypocalcemia and, if found, were given oral calcium supplement of 500 mg thrice a day. Patient with neuromuscular symptom receive intravenous injection calcium gluconate, 0.5 mg elemental calcium per kg per hour. Result: a total 74 patients included in this study, 23 are women and 11 are men. Cytological diagnosis being colloid goiter 46%, papillary carcinoma 11%, follicular neoplasm 7 patients, toxic nodular goiter 6 patients, autoimmune thyroiditis in 4 patients. Out of 74 patients, post-operative hypocalcemia developed in 43 patients. Out of 43, 34 are asymptomatic hypocalcemia and 9 are symptomatic hypocalcemia. Clinical symptom in symptomatic hypocalcemia, 9 were out of 9, 8 are transient hypocalcemia and 1 are permanent hypocalcemia. Patients were followed up with 12 months. There were no loss of follow-up and no more mortality in this study. These are graphs showing discussion. Post-operative hypocalcemia is one of the most common complications. According to literature, post-operative hypocalcemia is 50 to 68%. In our study, post-operative hypocalcemia developed in 58.1% of the patients. Rosato found that 10% of patients had symptomatic hypocalcemia. Temporary post-operative hypocalcemia develops more often in patients who have a markedly decreased level of serum calcium before surgery. A study conducted by Thomas et al. That hypoparathyroidism complication more in female patients compared to male patients. Post-operative hypocalcemia incidence is more common in advanced age group. In our study, incidence of post-operative hypocalcemia were approximately 58.1%. In literature, it was reported 27 to 80%. Benign disease show less incidence than malignant. In a study conducted by Sakoti et al. Regarding the incidence of transient and permanent hypocalcemia after total thyroidectomy for thyroid cancer, reveal higher incidence of hypocalcemia after total thyroidectomy in malignant disease of the thyroid. For prevention of post-thyroidectomy hypocalcemia, many authors follow identification of parathyroid gland intraoperatively. In another study conducted by Thomas et al., the incidence of transient parathyroid hypocalcemia was 6.4%, while permanent dysfunction occur in 1.5% of the patients. Most common preoperative clinical and radiological diagnosis in our study was multinodular goiter in 51 patients, while the most common pathological disorder by FNC was colloid goiter.
Ajay, be fast, only 30 seconds left.
This was similar result obtained in a study with the Nair et al. In our study, observed the incidence of hypocalcemia post-operatively reduced. In a study of Sihan et al., there are more incidence of hypoparathyroidism with less than 3 parathyroid glands were identified and preserved. Conclusion: thyroid surgery swelling more common in female, post-operative hypocalcemia more in advanced age and malignant condition. Most common complication of post-operative thyroid hypocalcemia. Transient hypocalcemia frequent complication, permanent hypocalcemia less common, which can be prevented by preoperative preparation of patient with extreme caution and intraoperative meticulous.
Your time is up, Ajay. Yes, the judges. I request judges to ask questions.
Dr. Ajay, how you like identify parathyroid gland during dissection of thyroid? Where you get?
Sir,
How it appears?
It's a small size of yellowish color, sir, in upper pole of and lower pole.
Is it exactly yellowish?
No, sir.
How it appears?
Just like brownie or sir.
Yes. Brownish orange. Okay. And how you have diagnosed non-symptomatic hyperparathyroid patient?
But sir?
How you have diagnosed non-symptomatic parathyroidism patient post-operatively? Because there is no symptom there.
Sir, to the investigate of calcium level, perioral numbness or tingling sensation.
Exactly. There is no symptoms, I'm saying. You go for every patient, you go for calcium, calcium estimation post-operatively.
First hour, sir, by ABG calcium level to see the calcium level.
Thank you.
Dr. Ajay, this is Dr. Vibhas from Dhanbad. What step, how prevent hypocalcemia?
Sir, mainly before operative, correct the hypocalcemia level.
Then what steps would you take to prevent hypocalcemia?
The hypocalcemia is mainly correcting the calcium before surgery and preserve the parathyroid gland during operative.
And suppose you have removed the parathyroid.
Yes, sir. Then auto transplant to either brachioradialis or substernal sternocleidomastoid.
Okay, thank you.
Dr. Ajay, yeah.
And now I request Dr. our next presenter to start sharing his screen and start his presentation. Haikino, up to you.
Thank you, sir.
Hello. Hello. Hello.
Yes, sir.
Am I
Yes.
audible? I am Dr. Uday Srivastav, Chairman ASI.
Welcome, sir.
Welcome, sir. Good morning, sir.
Good morning, everyone. I am a bit late due to some technical error. So please continue.
Okay, thank you, sir. And now, Dr. Haikino, start your presentation. Start speaking, Haikino.
Pankaj boss, good morning. Pankaj Budra boss, good morning.
Good morning, sir. Good morning.
Good morning.
Good morning. Morning.
Good morning, Dr. Azad. Good morning, Dr. Uday. Welcome to the hall. And just there has been a request is Sumegha from the participants here for the results of the poster yesterday here also, because they need to know for preparing for the poster presentation tomorrow. So we will declare once we are breaking for the orations. Okay? Okay. Yeah, continue.
Yes, Dr. Haikino, please start speaking. Start your presentation. Haikino, you're not audible.
अरे हम थोड़े ये उधर से तो आना चाहिए ना.
So is there something wrong? Haikino, why you're not speaking?
Am I audible?
Hi, now you're audible. Now start. Start your screen share and start presentation. Start your screen share, Haikino.
Is it visible?
Start your screen share.
Is it visible?
Share screen. Start your share screen. Yes.
Is it visible?
Yes, you start. Yes. Yes, start your presentation now.
Good morning, respected faculties, seniors, and my dear colleagues. This morning I'll be presenting a paper on clinical pathology study and management of benign breast disease at RIMS Ranchi. Benign breast disease is the most common cause of breast problems. Up to 30% of women may suffer from benign breast disease, requiring treatment at some point of time in their life. Far more attention are focused on breast cancer. However, benign breast disease are at least 10 times more common than the breast cancer in developed countries. This has resulted in many patients with benign breast disease receiving rather scant attention from clinicians, and there has been relatively little academic investigation into this complex subject. Aim of the study was to study the clinical pathology study and management of benign breast disease. Objective of the study was to study the age distribution of various breast disease, benign breast disease, to study different types of benign breast disease, their mode of clinical presentation and pathology, to study various types of management for different types of benign breast disease. A prospective study of females with breast disease coming to Rinchi over a period of 1 year was studied. A pre-designed performer was used to collect this information for individual cases. The data was collected based on pre-operative diagnosis made by the clinical evaluation, radiological and pathological investigation, and post-operative histopathological reports. Inclusion criteria: patient who got admitted are clinically diagnosed and confirmed by histopathological examination, representing various types of benign breast of the breast are included in the study. Both out and inpatient were included. Exclusion criteria: patient diagnosed clinically as benign breast disease, but in whom histopathological examination reports proved to be otherwise, were excluded from the study. Male gender was excluded. Coming to the result, a total number of 329 cases were studied over a period of 1 year. After considering the inclusion and exclusion criteria, the diagnoses were made after taking proper history, clinical examination, and correlating with radiological and FNC finding. Those undergoing surgery were further investigated with HPE examination of excised tissue. According to this study, most common benign breast disease was found to be fibroadenoma, accounting for about 57.45%, followed by fibrocystic disease, accounting for about 26.75%. Coming to the age distribution, approximately 87% of all the benign breast disorders fall below the age of 40 years in my study, followed by, and among the majority of them belong to age 21 to 30 years. In my study, 80% of the patients were Hindus, 9% were Muslims, and 6% were Christian, and other religion comprised of 5%. Socioeconomic status, 70.2% of and only about 2% were from upper socioeconomic status. And in the menstrual status, according to this study, benign breast disease are much more common in premenopausal and younger women age group, accounting for approximately 95% of the cases. Mode of presentation, my study, most common mode of presentation was lump alone, accounting for about 66%, and second most common being lump with mestalgia, accounting for about 24%. And 42.5% of my patients had disease on the right breast, while 38% of the patient had disease on the left breast, and bilateral breast involvement of benign breast disease was seen in around 19% of my cases. In the site of the lesion, upper outer quadrant of the right breast was the most common site in my study, and followed by central quadrant, accounting for 19.78%. According to this study, majority of the patient with fibroadenoma at the time of presentation were size of 3 to 5 centimeter, accounting for about 71% of my total fibroadenoma cases. Most of the phylloid tumor were presented to us when the size of the tumor had grown to be more than 10 centimeter, with 5 out of 6 cases in the study. Accuracy of FNS HP in fibroadenoma and phylloid tumor. Among 177 of my patients who were confirmed as fibroadenoma by HP histopathological examination following excision surgery, 175 were correctly confirmed as fibroadenoma by FNC, while 2 others were initially reported as fibrocystic disease of breast. True positive was 98.87%. However, excision biopsy stands as the ultimate investigation involved in cases of doubtful diagnosis and suspected malignancy, which has accuracy of 100%. Among 6 cases of phylloid tumor who were confirmed by histopathological examination, 1 case was initially reported as giant fibroadenoma. Coming to the management, among 329 of my cases in the study, 129 of them were treated conservatively, while 205 patients required some kind of intervention over the study period. And of 189 cases, 177 of them were treated with excision, while 12 were given conservative management. In fibrocystic disease, out of 88 of my patients, 77 were managed conservatively, and 11 others were given underwent surgical treatment eventually. All 6 patients with cystosarcoma phylloides were treated with simple mastectomy, as it involved most of the breast tissue. And breast abscess was treated mostly lactational and was treated by incision and drainage with antibiotic coverage. Let me come to conclusion. In my conclusion, I found that fibroadenoma was the most common benign breast disease, encountering about 57.45%, followed by fibrocystic disease. Fibroadenoma presented mostly in second and third decade. Lump in the breast was the most common presentation of benign breast disease. Mestalgia was the second most common symptoms of benign breast disease. And there was slight preponderance of benign breast disease commonly found the upper outer quadrant of the breast. 95% of my patients were premenopausal, and majority of the fibroadenoma presented to us at the size of 3 to 5 centimeter, accounting for about 71% of the total cases. Fibroadenoma accounted for about 5.8% of my cases. FNSE was used for planning and determining appropriate treatment modality. It was highly accurate in present study and was
20 seconds left, be fast.
Exceptionally reliable for fibroadenoma other than other breast lesions. Excision biopsy is the investigation of in doubtful cases. There is increasing evidence that conservative approach is acceptable in adolescent patients. Patient choosing conservative management should be informed about the limitation of the test and must be assessed probably if there is symptoms and clinical changes. However, in adult women, evaluation of triple test is prerequisite for breast conservative management. Benign breast cell examination should be emphasized as a part of female adult education. Thank you.
Judges, you are requested to ask questions.
Hello, Ikeno.
Good morning, sir.
Yeah, good morning. Can you differentiate between histosarcoma piloides with large fibroadenoma?
Usually, clinically, sir, if there's a large fibroadenoma, it may be clinically, it may not be always possible to differentiate between them. Both can have bosselated surfaces, and in histosarcoma phyllodes, there may be visible engorged veins.
Yes.
With similar consistency. But it may not always be possible to differentiate between them clinically, sir.
Okay, thank you.
Dr. Hakim,
yes, sir.
What are the tests to be performed to differentiate between benign and malignant?
Sir, firstly, based on the taking carcinoma may be is most commonly in older age group, and sir, based clinical examinations. Clinical examination of benign diseases are usually mobile in structures and usually with regular surface. And in malignance, there can be involvement of other tissues. There will be history.
What is the one diagnostic test you perform?
Sir, at first, initially, sir, for any kind of breast lump, we advise for FNSC, cytology, and with that ultrasound breast or mammography, sir. And then if there's any doubtful situation, then we go for excision by incision or excision or corneal biopsy.
Okay.
Yes, I'm sorry, now time for discussion. Thank you, Dr. Aikino. Thank you, judges. And now our next speaker, Dr. Apurv Kumar Nayak, is ready with his presentation.
Yes, ma'am.
Yes, Apurv, now you can start your screen share and start your presentation.
Ma'am, am I audible? And
yes, you are audible. Start.
Okay, ma'am. Good morning, respected teachers and my dear colleagues. Myself, Dr. Apurv Kumar Nayak. My guide is Professor Dr. Vinay Pratap. I'll be presenting clinical study of the spectrum of secondary peritonitis due to gastrointestinal perforation in a tertiary care center of Jharkhand. Introduction. Inflammation of peritoneum, that is peritonitis, is the most common surgical emergency and can result in devastating consequences unless early diagnosis and prompt treatment is done. There are four main mechanisms of intestinal perforation, that is ischemia, secondly infection, thirdly erosion, and lastly physical disruption. Peritonitis presents as an acute abdomen. Local findings include abdominal tenderness, guarding, rigidity, distension, and diminished bowel sounds. Systemic findings include fever, chills or rigor, tachycardia, sweating, tachypnea, restlessness, dehydration, oliguria, disorientation.
Just sorry to intervene.
Okay, ma'am.
We will have to break for the oration because we are starting the oration in the other hall and it's
Okay,
already
ma'am.
9:30. So because he has just started, so we will have this presentation after the orations are over. Is that all right, judges?
Okay.
Yeah, it's all
You
right.
can go
Thank you so
forward.
much. We can join in for the oration and after the oration, we will start the session again. Okay, thank you very much.
Thank you.
Thank you.
Okay, so after orations, we will have our sessions. Apur will be presenting after the oration.
Ma'am, time, can you tell me the time?
Pardon?
Time, ma'am, time.
After 1 hour, that
1
is
hour. Okay, ma'am. Okay,
10:30.
ma'am.
Okay.
Okay, ma'am. Thank you,
Just
ma'am.
join 5 minutes earlier.
Okay, ma'am.
Okay.
So we should move to Hall A.
Yes, sir. I think we should move to Hall A for orations.
Okay.
दिलों की
Okay, welcome back everyone to Hall B. Have all judges joined? I can see Pankaj sir. And
Yeah,
Jiao.
good morning again, all of you.
Good morning, sir.
Shall we start, sir?
Dr. Urva, you have your turn now.
Yes, sir.
Apurva was starting his presentation, right?
Yes, ma'am.
Yes.
I request all the documents and other devices so that we can get all these Hello, good afternoon. Good morning to all of you. Yes, I want to.
Dr. Sumega,
Yes, sir.
Dr. Sumega, are you there?
Yes, sir, I am here. So actually, I called Dr. Vibhas Sahai. He is joining shortly. So we are waiting for him.
Okay.
So shall we start, sir?
Okay, you can start now.
Okay, sir. Okay,
Thank you, sir.
Dr. Apur, start your presentation now.
Thank you, sir. Good morning, respected teachers and my dear colleagues. Myself, Dr. Apur Kumar Naik. My guide is Professor Dr. Vinay Pratap, sir. I will be presenting a paper on a clinical study of the spectrum of secondary peritonitis due to gastrointestinal perforation in a tertiary care center of Jharkhand. Introduction. Inflammation of peritoneum, that is peritonitis, is the most common surgical emergency and can result in devastating consequences unless early diagnosis and prompt treatment is done. There are four main mechanisms of intestinal perforation, that is ischemia, infection, erosion, and physical disruption. Peritonitis presents as an acute abdomen. Local findings include abdominal tenderness, guarding or rigidity, distension, and diminished bowel sounds. Systemic findings include fever, chills or rigor, tachycardia, sweating, tachypnea, restlessness, dehydration, oliguria, disorientation, and ultimately shock. The abuse of easily available over-the-counter NSAIDs in empty stomach for tiredness is common among our population. Upright chest and abdomen X-ray are quick and cheap to identify even small amounts of pneumoperitoneum. CT of the abdomen and pelvis, however, is the most sensitive and specific test to diagnose a perforation and ascertain the most likely etiology. Colonic perforation should be considered in a patient with a history of left lower quadrant pain or history of diverticulitis, usually with decreased stool output. Imaging typically shows free air located near the area of perforation with possible abscess formation due to leakage of stool into the peritoneal cavity. Rarely, free intraperitoneal air can be caused by benign pneumatosis intestinalis unrelated to ischemia and can be managed without surgical intervention. Aim of my study: to present the problem of perforation peritonitis due to various causes, to study the age, sex, incidence, and clinical features of perforation peritonitis, to find the commonest type and location of perforation in our study, to review the postoperative complications, and to understand better approaches of treatment. Materials and methods. The study is a hospital-based prospective observational study conducted at RIMS Ranchi from June 2018 to May 2020, which included 196 patients. The patients included were all of gastrointestinal perforation peritonitis undergoing exploratory laparotomy. Before laparotomy, examination and X-ray abdomen upright was obtained to see the presence of free gas under diaphragm, but the cases where patient's general condition and blood pressure were stable, ultrasound whole abdomen or CT scan of abdomen was done before posting them for surgery. Observation and analysis of the results were done in relation to patient particulars, history, clinical findings, laboratory findings, imaging reports, anatomical sites, and cause of perforation. Complications and outcomes were also noticed. Results and discussion. In this study, a total of 196 patients underwent surgery for secondary peritonitis. Among these, about 79% of them were males, and the male to female ratio was 3.78:1. The mean age of patients was about 42.46 years. Abdominal pain was observed in almost all the patients, followed by constipation, distension, vomiting, fever. There were about 28% patients above 50 years of age, out of which about 12% had some kind of previous comorbidities. The time taken by patients between the onset of symptoms and presentation to the hospital was more than 24 hours in 67% of the patients, which is majority. The table 1 shows the age distribution of the patients. The mean age of patients was about 42.46 years. The second table shows the etiologies of the perforation. Peptic ulcer perforation is the most common etiology, which is about 42%, followed by trauma, typhoid, gangrene, appendicular perforation, intestinal tuberculosis. This graph shows the etiologies as described in the previous table. This table shows the sites of perforation in the patients, and duodenum was the most common site with 27.04%, followed by stomach, ileum, colon, jejunum, and all. This graph shows the previous table, the sites of perforation. Duodenum has the highest patients. These are the pictures. Figure 1 shows duodenal ulcer perforation intraoperatively, and the second picture shows the repair that we do, omental patch repair, Ram's omental patch repair. Third picture shows colonic perforation, stool coming out from the perforation, and the fourth is ileal perforation. All the types of perforation possible has been shown in the picture. And this is the X-ray chest PA view. showing the free gas under the diaphragm in both sides. Table 4 shows post-operative complications of these operated patients, and most commonly found post-operative complication is the wound infection, followed by paralytic ileus, burst abdomen, and respiratory infections. This is the graph showing the post-operative complications. Wound infection has the highest. And the chest X-ray PA view or X-ray erect abdomen showed free gas under diaphragm in a majority of the patients, that is 73% about. But the maximum proportion was found in the acid peptic ulcer diseases and was never found in appendicular perforation. Only about 32% patients had presented within 24 hours of onset of symptoms. Overall mortality rate was 21%, out of which 18 number of patients had some kind of previous comorbidities. The mean hospital stay was about 13 days. Conclusion is most common age group in our study is 30 to 50 years, with duodenum as the most common site of perforation. Pain is the most common symptom, and peptic ulcer perforation is the most common etiology in our study. Post-operative surgical site infection is the most common complication seen in our patients. The important factors clearly deciding the fate of the patient with perforation peritonitis are early diagnosis, resuscitation with fluids and electrolyte balance, timely surgical intervention, appropriate use of antibiotics, and eliminating the source of infection. These are my references. Thank you.
Good.
Thank you, ma'am.
Yes, now judges, you can ask questions. Stop your screen sharing, Apur, and judges,
Okay.
you can ask questions.
Dr. Apurva.
Yes, sir.
This is Dr. Vibhas. Can you tell me something about the excessive use of NSAIDs in the etiology of peptic perforation?
Yes, sir. The NSAIDs are available over the counter, sir, and these are responsible for peptic ulcer perforation in patients commonly in our population. And sir, NSAIDs usually increase if there is a previous ulcer. It will increase the erosion, and it aggravates the rate of perforation in patients.
Okay, thank you.
What are the most common perforation you get in your setup, and what are the treatments available for that?
Sir, most common type of perforation we see is peptic ulcer perforation, sir, in our setup. And
Yes.
We usually go for Graham's omental patch repair in these patients.
If large perforations are there in duodenum, what you will do? If it's not repairable?
So if there are there is large perforation in the duodenum, it is least likely to be repaired by omental patch repair, sir. In those cases, we usually there are various. They consider various methods, sir. One we can do is, sir, we can create a controlled fistula at the site and create a feeding jejunostomy distal to it, feeding for temporary management. And other than that, we can also do gastrojejunostomy and repair the site of perforation.
Okay, thank you.
Hello, Dr. Naik.
Yes,
here is Dr. Ziaul Haq. You are audible?
Yes, sir.
Oh, good morning.
You are audible.
Is there any role of H. pylori eradications for?
Yes, sir. Yes, sir. Yes, sir. H. pylori has definite role in.
Patients are selected.
Yes, sir. Could not get the last question, sir.
In all cases or in some few cases, limited cases, H. pylori eradications.
Sir, H. pylori has role in both in gastric as well as duodenal perforation, and sir, its role is proven, and so almost all the patients of peptic ulcer perforation should be treated with anti-H. pylori drugs. Okay. And sir, it also increases the recurrence. It decreases the treating the it increases the recurrence, and we, by treating the H. pylori, we decrease the chance of recurrence of ulcer.
Okay,
Okay,
nice.
thank you, Dr. Apu. Thank you, judges, because our discussion time is over. Now we move on to our next presenter, Dr. Akash Gupta.
Yes, ma'am.
Akash, you can start your screen share and start your presentation.
Yes,
Over
ma'am.
to you, Akash.
Good morning, my teachers. I will be presenting an observational study in pediatric age group undergoing emergency laparotomy in tertiary health center. My guide is Dr. Marshall Kalkutta, sir. Hello, I'm audible? Hello.
Yes, you are audible. So keep saying.
Yes, sir. Introduction. Acute abdomen can be defined as syndrome induced by a wide variety of pathological conditions that require emergent medical or more often surgical management. Acute abdomen is caused due to gastrointestinal diseases such as intestinal obstruction, perforation, peritonitis, and acute appendicitis. The causes of obstruction in children are anorectal malformation, intussusceptions, Meckel's diverticulum, abdominal cocks, congenital band obstruction, Hispin's disease, ascariasis, postoperative bands, and adhesions. Intussusception remains a common cause of bowel obstruction in young children and results in significant morbidity and mortality. Typhoid inlet perforation is still prevalent in developing countries like ours and is associated with high morbidity and mortality in children. In our study, total 77 children aged below or equal to 15 years underwent emergency laparotomy for acute intestinal obstruction and intestinal perforation peritonitis. It was conducted in between January 2019 to December 2019. We excluded neonates, patients of jejunal-ileal colonic atresia and stenosis, anorectal malformations, congenital pouch colon, neonatal necrotizing enterocolitis, Hirschsprung's disease, gastrointestinal tumor. Diagnosis was made by clinical history and examination supported by plain X-ray and ultrasound of abdomen and pelvis. Out of total 77 laparotomies we performed, 59 were boys and 18 were girls with male is to female ratio of 3.2:1. 20 emergency laparotomies was performed in the age group of 1 to 5 years and 57 were performed in the age group of 15 years. 5 to 15 years. Here total cases is 77. The one I discussed before, the male is to female ratio of 3:1, 3.2:1. And in between 1 to 5 years, the cases operated for intestinal obstruction was 11 and perforation peritonitis was 9. And 5 to 15 years for obstruction was 25 and perforation peritonitis was 32. Out of total 77 laparotomies, 36 laparotomies were performed for acute intestinal obstruction and 41 for intestinal perforation peritonitis. The causes for intestinal obstruction is shown in the chart here, of which the most common was intussusception, followed by postoperative band adhesions, abdominal TB obstruction, Meckel's diverticulum, and worm obstruction. Causes for perforation peritonitis, which we found in a study maximum, was typhoid ileal perforation, followed by abdominal TB causing obstruction, followed with perforation, appendicular perforation, and abdominal trauma. The most common surgical cause of acute abdomen in children is appendicitis, but we have excluded acute appendicitis but included laparotomy due to appendicular perforation. Intussusception remains a commonest cause of bowel obstruction in young children and has been reported by many authors. Other causes of intestinal obstructions are Meckel's diverticulum, adhesions, ascariasis. The commonest cause of intestinal obstruction in our study was also intussusception, followed by postoperative band adhesions, abdominal TB obstruction, Meckel's diverticulum, and worm obstruction. Ileal perforation peritonitis, mostly due to typhoid perforation in children, is the leading cause of peritonitis and is prevalent in many developing countries. The causes of perforation peritonitis in our study we found was typhoid, which was the most, and cases followed by abdominal TB, appendicular perforation, and abdominal trauma cases. Plain radiograph of abdomen in erect position are most useful when intestinal obstruction perforation of viscous is the concern. Majority of cases of acute abdomen in children, USG of abdomen pelvis can provide specific diagnosis. In our study also, diagnostic workup of patients included detailed clinical history examination and supported plain X-ray and USG of abdomen pelvis. The surgical operatives at laparotomy for perforation peritonitis are cleaning of contamination into the peritoneal cavity with either one of the following: primary repair of perforation, segmental resection of diseased bowel, anastomosis, creation of stoma, depending on the condition of involved bowel segment. We have operated 41 cases of perforation peritonitis in children, of which 35 were boys and 6 were girls. 9 patients were in the age group of 1 to 5 years, and 32 patients were 5 to 15 years of age. The surgical treatment done in our study was simple primary closure of perforation after freshening of margin, segmental resection, anastomosis, ileostomy, and abdominal drainage. Intussusception remains the most common cause of intestinal obstruction in children and result in significant morbidity and mortality. Treatment options for interception are hydrostatic or barium enema reduction, expiratory laparotomy, or manual reduction, segment oval resection for gangrene and anastomosis. In our study, we operated a total of 16 cases of interception, of which 10 were boys and 6 were girls. Maximum were in the age group of 5 to 15 years of age, and only 6 cases were in 1 to 5 years of age group. In 5 cases, operating manual reduction was possible. 6 cases had gangrenous bowel, required bowel resection, while 5 other cases reduction was not possible, hence required resection. Meckel's diverticulum may present as diverticulitis, intestinal obstruction, perforation, peritonitis, intestinal bleeding. Treatment options are resection of diverticula, wedge resection, anastomosis, segmental resection with Meckel's and anastomosis, and can be done by open surgery or laparoscopically. In our study, 3 patients of Meckel's diverticulum we have seen, and all 3 patients were having Meckel's diverticulum with gangrene of bowel segment, in whom resection of gangrenous segment was done with ileostomy. Abdominal TB is usually treated conservatively with anti-TB drugs alone, but patients presenting with acute intestinal obstruction and perforation peritonitis may need laparotomy for diagnosis and relief of bowel obstruction and perforation. We included 15 cases of abdominal TB, of which 7 patients presented with intestinal obstruction and 8 cases presented with perforation peritonitis, which we have seen in the chart previously. The operative procedure done where adhesiolysis and biopsy was taken, ileotransverse anastomosis, or bypassing the stricture and ileostomy. Ascariasis is the infestation by large intestinal nematode of man attributed to poor hygiene and low socioeconomic status. Most cases of intestinal obstruction due to Ascariasis lumbricoides can be managed conservatively. However, emergency surgery like enterotomy, milking of worm in the large intestine section, and anastomosis needed in patients with features of gangrene and perforation. We had in total 2 cases of worm obstruction whom enterotomy was done for removal of bunch of worms. Conclusion. In our study, maximum emergency laparotomy was performed in male patients with male to female ratio of 3.2:1. Perforation peritonitis was more common than acute intestinal obstruction. 5 to 15 year age group were more commonly affected. Typhoid ileal perforation was more common for exploratory laparotomy, followed by interception. The other causes we encountered in our study was abdominal TB, post-operative band saltations, appendicular perforations, Meckel's diverticulum, and worm obstruction. These are my references, sir. Thank you, sir.
Very good, Akash. You have finished in time.
Yes, ma'am.
And now,
Dr. Akash.
Judges are welcome for questions.
Yes.
Yeah, Dr. Akash, this is Dr. Parvez. Nice presentation.
Morning, sir.
But I have a very small observation to make. Your slides are too crowded. It is very difficult to go through at one time. Have you compared your study with other studies?
Yes, sir. I have compared with other studies.
Yeah. And what was the take-home message?
So, as it was an observational study, sir, so we intended to find the common causes for which the patients in our Jharkhand are undergoing exploratory laparotomy, sir. And which we encountered was perforation peritonitis was the most common, which was more common because of enteric perforation, sir, which was followed by interception, which was another leading cause for obstruction in children in our region, sir.
Thank you.
Dr. Akash.
Yes, sir.
Can you name, adult causes of interception?
Adult causes of interception,
yeah.
sir. Yes, sir. It can be because of submucosal lipoma as a lead point, because of polyps, because of any malignancy.
Yes, and what you understand, and or can you differentiate between false and true diverticulum?
False and true diverticulum, sir.
Is it with the layers of diverticulum?
Yes, sir. In true diverticulum, all the layers of the intestine will be present, sir.
Yeah.
And false, only the mucosa will be
coming out too. Yes. Okay. Thank you.
Hello, Akash. Hello, here is Dr. Ziaul.
Morning, sir.
Yes, audible to me? Audible?
Yes, sir. Yes, sir. Morning, sir.
Okay, okay. So what is the most confirmatory investigation for interception in your series? Which modality of investigation you have used?
So as our study included, only the emergency patients, so we used only X-rays and USG. So the USG was one of the confirmatory investigation for us, sir.
Okay, okay. Thank you.
Thank you.
Okay, nice.
Dr. Akash, have you tried to reduce the interception ever by enema barium enema and all?
So in our study, we encountered all the emergency cases, sir.
Okay.
So that's why we needed to go for laparotomy because the features of peritonitis was already present, sir. And yes, sir.
Okay. What's the investigation of choice in acute appendicitis?
For in children's, the investigation of choice is ultrasound abdomen, sir.
Okay.
Okay, thank you, Akash. Thank you. Now I call
Thank you,
upon
sir.
speaker, Neeraj. Yes, Dr. Neeraj. Good morning. Yes, and start your screen share and start your presentation.
Yes, ma'am.
Your topic is outcome of laparoscopic CBD exploration, right?
Yes, ma'am. Yes, ma'am.
You start your screen share.
Yes, ma'am.
Don't waste time.
Good morning, everyone. Our topic for today is outcome of laparoscopic common bile duct fixation at Tata Motors Hospital. I am Dr. Neeraj, DMB third year resident, Department of General Surgery, Tata Motors Hospital, Jamshedpur. My name is Dr. Sanjay Kumar. Choledocholitis is stone or sludge in the CBD or common hepatic duct. Choledocholitis is defined as identified in 10 to 15% of the symptomatic choledocholitis. The primary challenge is to select the best strategy with respect to the invasive surgery era. ERCP and laparoscopic techniques are used. Aims and to study the outcome of the laparoscopic common bile duct exploration with respect to the morbidity and clearance rate. My primary objective is the bile duct stone clearance rate, while my secondary objective is to see the bile leak rate post-operatively, hospital duration, and port-side infection. Periods of all patients presenting with CSI equals to 10 of observation study using formula 4p 1 n equals to, using the formula n equals to 4p 1 minus p upon e square. According to the formula, 45 patients who are fulfilling the eligibility criteria are taken. The standard 4-port configuration of lap chole will be used. A 5th port will be made in between the right mid-clavicular and epigastric port, just below the subcostal margin, for inserting the choledocoscope. Choledocostomy were closed over a T-tube with continuous 30 micro suture. Inclusion criteria: all patients diagnosed cell duct should be more than equals to 10 mm, willing to participate in the study after consent. Exclusion criteria: intrahepatic biliary bile duct stricture identified before surgery, biliary tract malformation, tumor of the hepatobiliary system, any cardiopulmonary disorder that would contraindicate surgery. Results: bile duct clearance rate. T-tube cholangiogram was performed at 10th to 14th day to see the bile duct clearance rate. The T-tube cholangiogram reveals filling defect in 4 patients, that is 8.9%. Therefore, clearance rate is 91.1%. Distribution of the bile leak and its consequences. Bile leak was found in 6 patients, that is 13.3%. USG guided drainage was carried out in 3, that is 6.7% cases, and drain retained in 2 cases, that is 4.4% cases. In 1 patient, further exploration was required. The definition of the bile leak which we have taken was: bile leak is defined as the fluid with increased bile concentration in abdominal drain after post-operative day 3, or interventional drainage is required, or we have to do a exploratory laparotomy due to biliary peritonitis. Prevalence of the port site infection. Infection was seen in 6 patients, that is 13.3% patients. Distribution according to the hospital stay. Hospital stay of more than 5 days was observed in 23 patients, that is 51.1% patient, and less than 5 days was seen in 22 patients, that is 48.9% patient. Clearance of the bile stone, other study, clearance rate.
Oh, Dr. Neeraj, what's wrong with you? You are not audible nor visible. I think Neeraj, you're not audible nor visible.
Mean day of hospital stay was for 4.75 plus minus 0.5 with a range of 3 to 10 days. While while in other studies like
Start
Salma
your
et al, it was seen to be 4 to 15 days. Ma'am, I am audible.
Yes, you continue.
Yes, sir. Prevalence of the port site infection. In our study, it is found to be 13.3%, while in DOKB et al, it is 10%, while in Karthik et al, it is 1.8%, while in Myral et al, it is 6.7%. Port site infection is more than other studies. While bile leak rate. The incidence of the bile leak after laparoscopic common bile duct exploration varies dramatically. It might be due to the different definition of the bile leak after biliary surgery among different centers. In our study, it was 13.3%, while in Leo D et al, it was 11.3%, while Hayo J et al, it was 3.8%. Limitation of the study. There is a lack of the long-term outcome, including data on recurrence rate with laparoscopic common bile duct exploration. Conclusion. With respect to the result obtained from our study, following conclusion can be drawn. The clearance rate of CBD stone in our study was 91.1%. Mean day of hospitalization was 4.75% plus minus 0.5 with a range of 3 to 10 days. The prevalence of the port side infection was 13.3%, while bile leak rate was found to be 13.3%. Takeaway message: the laparoscopic common bile duct exploration is more desirable due to several important reasons. The reduction of the inconvenience by offering a one-stage procedure in laparoscopic common bile duct exploration compared to the other stage approach of ERCP following by laparoscopic cholecystectomy. Laparoscopic common bile duct exploration is cost-effective and permits early recovery with a reduction period of short term of disability. Thank you.
Hello.
Yes, sir.
Dr. Neeraj. Dr. Neeraj.
Yes,
You have your data suggesting it to be it's around 8.9% stones are left over there. What do you do with those stones? Which am I audible?
Sir,
You are audible.
yes, sir. Yes, sir. Yes.
Huh? Understand
Sir, we
my
send
question?
those patients further for. Yes, sir. Yes, sir. For the remaining 8.9% of the patient, which we have found to be have a stone in the T-tube cholangiogram, we send
Yes.
those patients for ERCP, sir.
Okay. What are the other methods by which you can remove all those stones in CBD?
Sir, we can use the open CBD exploration. And
what else?
We can also flush the T-tube for removing the stone if it's remained there.
Okay. Thank you.
Hello, Neeraj.
Yes.
Hello, Neeraj. Here is Dr. Ziaullah.
Yes, sir.
Hello.
Yes, sir.
Yes, just one question to you. What are the ideal indications for laparoscopic CBD exploration? Would you like to explore all the all the stone through laparoscope, or there are some definite indications?
No, no, sir. There are definitive indications. The CBD should be more than equals to 10 mm of the diameter, and most probably the stone should be single stone. We can
Stone
also
should
do
be?
it for multiple stone, but it's single stone, sir. Mostly single or one or two stone, not multiple stones.
Okay. And the location of the stone, site of the stone is also important. Mid CBD, proximal, distal.
Yes, sir. It's mostly distal stones, which we used to prefer here.
Distal or mid?
Sir, distal and mid, not proximal stones, sir.
Okay, thank you.
Dr. Neeraj, do you pass T-tube in each case? Or,
Yes, sir. We are using T-tube in all the cases.
Okay, thank you, Neeraj. Thank you, judges. So I call upon our next speaker, Dr. Kunal Kishore, for his presentation. Kunal?
Yes, ma'am.
First, unmute yourself.
Good morning to everyone.
Over to you, Kunal.
Today I am going to present a paper on the topic gallbladder perforation during laparoscopic cholecystectomy and its incidence and consequences. Gallbladder perforation is one of the most common intraoperative complications occurring during laparoscopic cholecystectomy with an incidence of 10 to 33% as reported in the literature, while the incidence of stone loss is unknown. The perforation of GB is almost always associated with spillage of bile and gallstones in the peritoneal cavity, which might lead to some early as well as late complications years after surgery. Complications are more common after spillage of both bile and stones rather than bile only. In majority of the cases, spilled stone usually cause no symptoms and complications occur in only a small proportion of patients. The aim of this study was to assess the incidence of gallbladder perforation during laparoscopic cholecystectomy and its consequences after the surgery. It was an observational study done at the Department of Surgery, RIMS Ranchi. All the patients between April 2019 and June 2020 who went laparoscopic cholecystectomy for symptomatic gallstone diseases were included in the study. The patient who didn't give the consent, had multiple comorbid conditions, and history of multiple operations in past were excluded. Various preoperative risk factors like age, sex, history of previous attacks in past, previous surgery in past, body mass index, total leukocyte count, etc. were assessed for relationship with GB perforation. Also, post-op complications like surgical site infection, abdominal pain, ileus, fever, etc. were compared with cases with GB perforation for any association. Observation and results. Total 234 patients who underwent laparoscopic cholecystectomy were included in the study, out of which 82.5% were female and 17.5% were male, showing a higher incidence of gallstone among the female patients. Only 32 patients had GB perforation, of which 19 patients had spillage of both bile and gallstones, while only 13 had spillage of bile. This is a pie chart showing the distribution of mode of gallbladder perforation. In 72% of the cases, the perforation of GB occurred during grasping and traction of the GB, and in 22% of the cases, the perforation of the GB occurred during dissection of the GB from the liver bed, and in 6% of the cases, the perforation of the GB occurred during extraction of the GB from the abdomen. This is a bar graph showing relationship between bile spillage and surgical site infection, showing higher rate of infection in the people with both bile and gallstone spillage. GB perforation occurred in 10 male patients and 22 female patients. The mean age of the patients with perforated GB was 48.2 years, and the mean TLC count in patients with GB perforation was 9,150 cells per mm cube. The average duration of surgery as well as the average duration of post-op stay was higher in the perforated group. This is the table showing the association between the pre-op risk factor and the GB perforation. On analyzing the pre-op risk factors for GB perforation, a significant association was seen between age greater than 50 and GB perforation, BMI greater than 30 and GB perforation, history of previous attacks and GB perforation, and age greater than 50 and GB perforation. No significant association was present between GB perforation and raised TLC count, raised ALP, history of previous surgery, and the number of stones in the GB. Only 5 patients out of 32 in the perforated group developed the surgical site infection, while 6 patients out of 202 in the non-perforated group developed the surgical site infection. Comparison of the clinical outcome in patients with GB perfusion versus no perforation. It was found that the patients with GB perfusion had a higher incidence of abdominal pain, post of fever, ILS, and surgical site infection. And on performing the chi-square test, a significant association was seen between GB perforation and post of fever, abdominal pain, ILS, and surgical site infection, whereas no association was seen between raised TLC count after GB perforation and intra-abdominal abscess following GB perforation. Discussion. In this study, the incidence of GB perforation was 13.6%, which is in accordance to the ranges mentioned in the literature. In this study, among the patients with GB perforation, 100% of the patient has a spillage of bile, while 50% of the patient has a spillage of stones. And this result is similar to the study conducted by Jasicon, in which bile spillage was present in 97% of the cases and gallstone spillage was present in 47% of the cases. In this study, in spillage group, 53% of the patient has persistent abdominal pain, while only 5.5% of the patient in non-spillage group had persistent post-op pain. And there was significant association present between spillage of gallbladder content and more post-operative abdominal pain. This finding was higher as compared to the study conducted by Jasicon et al. And Rice et al. In the spillage group, in this study, 15.6% patient had post-op fever, while only 3.5% of the patient in non-spillage group had fever, and a significant association was present suggesting spillage of gallbladder content is associated with post-operative fever. This was consistent with the study done by Rice et al. In which the incidence of post-op fever was 18%. In a spillage group, 18.7% of the patient had post-operative ILS, while only 4.5% of the patient in non-spillage group had post-operative ILS. Whereas in study by Rice et al., only 1.3% of the patient had ILS. The rate of wound infection varies greatly from 1% to 14.5% in studies conducted by Javan et al. And Malatani et al. And in our study, the incidence of surgical site infection in the spillage group was 15.6%. No significant association was observed within GB perforation, duration of post-op stay, drain removal, which is consistent with studies conducted by Memon, MA et al. And Jassim et al. Only one patient in the spillage group developed a subhepatic abscess around 20th post-op day, which was managed with percutaneous ultrasound-guided drainage. And also, in study conducted by Jassim et al., the 8.8% of the patient had developed intra-abdominal abscesses. Conclusion. Complications are more common after spillage of both bile and stones rather than bile only. Every attempt should be made to search for spilled stone and they should be retrieved. Documentation must be done by the operating surgeon. Regarding the GB perforation, if spillage occurs, first and foremost thing to do is to do a normal saline irrigation of the peritoneal cavity and aspiration. All possible complications and their symptoms should be explained to the patient and the patient party. The surgeon should keep a long-term follow-up of such patients. Most of the complications of the spillage can be managed by minimal invasive techniques like percutaneous drainage of abscess. These are my references. Thank you, everyone.
Very nice. Dr. Kunal, you have finished within time. And now just open for the judges to ask your question.
Dr. Kunal, it's a nice presentation.
Thank you, sir.
Hello, Dr. Kunal.
GB stone
Yes, ma'am.
spillage.
Yes, sir.
If stones spills
Yes, sir.
around GB and between intestine, what will do with those stones and what are the complications?
Sir, if the stone pillage occurs intraoperatively, we will try to pick up the stones as much as possible because the left stone can lead to intra-abdominal abscesses, also can lead to distant abscesses from that site also, sir. And they can also lead to port site infection and granuloma, sir. Granuloma formation at the port site.
Okay, thank you.
Okay. Dr. Kunal.
Yes, sir.
Dr. Kunal.
Yes, sir.
Dr. Ziaul. Hello.
Yes, sir.
Is there any role of abdominal drain in such kind of situations?
No, sir, exactly. There is no such use of abdominal drain because after proper suction and irrigation, most of the bile can be aspirated. And the gallstone which are left, it is very difficult to say that the gallstone will follow the drain or not.
So there is no role of, we don't preferably put intra-abdominal drain in such cases, or we put?
Sir, it depends on the surgeon, sir. Many people put, people don't put, sir.
Dr. Kunal.
Yes, sir.
What percentage of patient you had put a drain? what number of patients or percentage of patients you have kept a drain post-operatively?
Sir, out of the 32 patients which had perforation, the drain was kept only in about 7 patients, sir.
Dr. Kunal.
Yes, sir.
Many a times it's not possible to prevent spillage.
Yes,
but
sir.
can you tell a few steps to prevent spillage of the stones?
The first and foremost step is, sir, to hold and to give the traction to the GB, definite amount of traction to the GB, not very much so that the GB ruptures during traction only. And also, sir, after the dissection of the GB and after we are clearing it from the liver bed, proper use of the cautery must be done to prevent excessive damage to the GB wall. And after the GB has been dissected, it must be kept in a pouch of plastic pouch and safely taken out through the port.
Good.
Very good, Dr. Kunal. And now we end the question session here because time is over. And now I move on to our next speaker, Dr. Chandan. You are ready? Yes. Dr. Chandan, you can now start your presentation.
Good morning, everyone. Am I audible, ma'am? Hello.
Yes, you are audible. Continue.
Good morning, everyone. I am Dr. Chandan Samal. I will be presenting a paper on comparative study between continuous and interrupted suture in midline laparotomy in emergency. So, introduction. The midline laparotomy incision is the most common incision used to open the abdomen in both emergency and elective surgery because it is simple, give quick exposure to 4 quadrant in the with minimum blood loss. Among many complications, most common complication is dehiscence associated with the closure of midline laparotomy incision. Midline laparotomy incision, which further causes post-operative morbidity. The wound dehiscence is related to many factors related to patient, material use, closure method. Minimization of tissue injury is necessary, and this can be done by avoiding incision of abdomen musculature at the time of closure. Mass closure of abdomen wall is recommended over layer closure. Use of non-absorbable suture over slowly absorbable suture one has not shown any difference in incidence of incisional hernia formation, wound dehiscence, or surgical site infection. The type of closure may not be important in elective surgery where patients are well nourished, have minimal chance of wound dehiscence, and well prepared for surgery. However, it is crucial in emergency patient with peritonitis and often has many risk factors for wound infection. Aim of the study. The study aimed to evaluate prospectively the continuous suture with interrupted type of suture in mass closure of abdomen laparotomy wound with slowly absorbing monofilament suture such as PDS in patient undergoing emergency midline laparotomy. For effectiveness in preventing burst abdomen, length of the suture used, time taken for closure of rectus sheath. Methodology. A total 60 patients undergoing emergency laparotomy for acute peritonitis were allotted for the study. 30 of them underwent closure for abdominal wall with continuous suture, group A, and the other 30 underwent interrupted suturing, group B, with late absorbable suture such as PDS. All necessary preoperative data, time taken in rectus closure, length of suture material required, post-operative complication like wound infection and dehiscence were analyzed. So the first picture shows the continuous abdominal suturing, and the second picture shows the interrupted abdominal suturing. Result. The observational study group divided into 2 groups of 30 each. Group A, patient with continuous suture of abdominal wall using PDA suture. Group B, patient with interrupted closure of abdominal wall using PDA suture. Patient of age between 22 to 70 were included in the study. The mean age group of subject was 40.3 plus minus 10 year for group A, and for group B it is 44.3 plus minus 12. Both groups are compared with respect to age. Most of them are male. Diagnosis. The most common encounter diagnosis was duodenal ulcer perforation, and the second most common is the gastric perforation. This table shows the common causes of abdominal peritonitis that we encountered during study. Time taken for closure of abdominal wall. The average time taken in the closure of abdominal wall in group A, that is in continuous suturing, was 15 plus minus 5 minutes, and the time taken for closure in group B, that is interrupted, that is 30 plus minus 3 minutes, which was significantly more, although the length of the incision were approximately same in the both group. suture length. The mean suture length used was 80 plus minus 10 second in group B, that is for continuous suturing, which was significantly less in group B, which was interrupted, which was 120 plus minus 10 centimeter. Wound infection. Midline incision site infection was noted in total 12% patient, 12 patient out of 30 patient in group A and 8 for 30 patient in group B. There is slight difference between two observations regarding the wound infection. Wound dehiscence. Incidence of wound dehiscence was recorded in both the study group. The average postoperative day for wound dehiscence is 7, and but it may occur between first day to day 30 of postoperative day. 90% of cases presented before 15th postoperative day. Wound dehiscence occur in 20%. In group A, 9 out of 30 patients develop wound dehiscence, and in group B, 3 out of 30 patients, that is 10% patient, develop wound dehiscence. This signifies that patient with interrupted suture has a less incidence of wound dehiscence. Discussion. The method which maintain the tensile strength throughout the healing process with well tissue approximation considered best. This should be well tolerated by the patient and technically simple. There is no definite surgical technique for closure of abdominal wall in emergency setting due to no clear demonstration in any related literature. As per the study finding, the time taken for closure in continuous technique, that is group A, was 15 minutes less than interrupted technique. The difference in time that can be minimized by running continuous closure suture without having multiple knots. In our study, the mean suture length used in the interrupted closure is 120 plus minus 10 second in group B, while the suture length used in continuous suture is 80 plus minus 10 centimeter in group A. The mean suture length used in group B is considerably more as compared to group A. As per the observation, wound infection, the wound infected cases is more in group A as compared to group B, that is in interrupted cases. In total, 33.3 of the wound got infected. Total wound dehiscence recorded at 20% of the patient. It was 30% in group A, that is with continuous suturing, and 10% in group B, that is in interrupted suturing. There is significant difference between these two groups. Some Indian authors have reported burst abdomen to occur in 10 to 30% emergency cases. Kumar et al. In his study, in which 100 patients included that with interrupted technique is better than continuous technique for abdominal wall closure, and it is prevented, and it will prevent burst abdomen significantly, both in emergency as well as in elective laparotomy cases. With the burst abdomen rate 2% in interrupted suturing and compared to 12% in continuous type of suturing. Conclusion. From the above study, we concluded that interrupted suturing is better than conventional suturing in the closure of midline laparotomy incision, as the post-operative complication like wound dehiscence is significantly lesser, but in case of interrupted suture, more suture material is required. The time taken for closure of the abdominal wall was more in case of interrupted suturing. These are my references, sir. Thank you, sir.
Okay, thank you, Dr. Chandan.
Thank you.
Now, judges, you can ask your questions.
Dr. Chandan.
Yes, sir.
What should be the suture length to ratio of suture length between the incision and the suture length?
If the incision is X, the suture length should be 4X, sir. 4:1, sir. That is a 4:1 ratio, sir.
Okay, okay. And what are the steps to open a paramedian incision? Can you give the steps? How you open
sir, we first paramedian incision, sir. Right, sir, first we open the skin, sir. Then rectus sheath is opened, sir. Paramedian, sir. Then we approach to peritoneum, sir. Peritoneum is closed. Peritoneum is open.
Okay, okay. Next, judge, please.
Hello, Chandan.
Yes, sir.
Yes, I'm Dr. Ziaula. Just yes, one question.
Yes, sir.
The incidence of incisional hernia is in which type of closure? It is interrupted or yet continuous? Have you observed this kind of things?
In my study, sir, I have not observed this incidence.
Any type of any incisional hernia?
But sir, the incisional hernia is more common in case of, sir, continuous suturing, sir.
Okay, but in your series, I'm just asking about your
Yes, sir. In my study, sir, incidence is more in incisional hernia, sir, in continuous type of suturing, as the burst abdomen is more common that can cause to it.
Interrupted less.
Yes, sir.
Okay.
Chanda, how did you manage the burst abdomen in your cases?
There is a patient develop burst abdomen, then we go on continuous series of antiseptic dressing with normal saline. When the complete infection is completely subsided with no pus in the abdomen, then we may close mass closure can be done for the burst abdomen, sir.
How is it different from the earlier closure?
Sir, in case of normal,
is it different from the earlier? Yeah, you said interrupted closure. Is it different the second time or the same
yes,
procedure?
In the second time, sir, we do mass closure, sir, with including rectus as well as the skin, sir. In my study, sir, I did the interrupted suture for rectus, then skin, sir. In case of burst abdomen, we included rectus and skin at a time, sir. That is in mass closure type, sir.
Okay.
Dr. Chandan,
Yes,
I'll
sir.
just suggest one thing. Even if you take continuous suture,
Yes,
you
sir.
should take some interrupted sutures in between to strengthen the wound. That helps a lot.
Yes, sir. Thank you, sir.
Thank you, Dr. Vivas, for giving such a good tip.
Thank you.
Chandan. And now I call
Thank you,
upon
sir.
our next presenter, Dr. Anish.
Yes, ma'am. Yes, ma'am.
Okay. Now start your screen
Video,
share
video,
and
video.
start your presentation. Start your screen share, Anish. It's a long session, don't waste time. Start your screen share.
Hello.
ठीक है चल ये ना
Hello. And I'm hello.
Yes, start your presentation.
Yes, yes.
You are audible. Start your presentation.
Hello. Good morning, everyone. My paper presentation is on clinical study of gastric outlet obstruction. Introduction. Gastric outlet obstruction is a clinical condition in which there is obstruction or complete mechanical obstruction of stomach to its content and cause. Or it impedes gastric emptying. It is largely been categorized into malignant and benign. Formerly, benign causes were more prevalent, but due to introduction of H2 receptor blocker and proton pump inhibitor, it has been decreased. Now, large number of cases of gastric outlet obstruction are due to gastric carcinoma. The proximal stomach is now the most important and the most common site of gastric carcinoma in West, but in Japan and developing countries like India, the distal gastric cancer is still predominant. The most common symptoms are abdominal fullness, early satiety, vomiting, and weight loss. Early symptoms are epigastric fullness or heaviness after meal. Later, vomiting may develop. That typically occurs 1 to several hours after eating and consists of partially digested food eaten that day or the previous day. That vomitus is characteristically totally lacking in bile. The patient commonly complains of losing weight and appears unwell and dehydrated. The clinical picture of outlet obstruction due to carcinoma of pylorus resembles benign gastric outlet obstruction more rapidly than do peptic ulcer. Characteristic feature of malignant gastric outlet obstruction are history is short. They may or may not be any previous history of peptic ulcer. Anorexia, nausea, vomiting rates are constant. Vomiting affords little relief. The vomiting is offensive. containing altered blood, coffee ground vomitus. Loss of weight is marked. There may be severe. They may be severe. There may be severe cachexia. Aims and objective. My aim is to observe the various causes of gastric outlet obstruction in tertiary care center RIMS, to determine the incidence of benign and malignant gastric outlet obstruction, to study modes of presentation of gastric outlet obstruction, evaluation of electrolyte abnormalities in gastric outlet obstruction, to analyze the outcome of treatment modalities applied in different cases. Methods. Prospective observational study comprising 60 cases of gastric outlet obstruction. All patients are selected from RIMS Ranchi, with features of gastric outlet obstruction presented in emergency from January 2019 to May 2020. These cases, both are of benign and malignant, form the material of my study. Cases are decided and characterized on the basis of their age incidence, sex incidence, their causative risk factors, socioeconomic status, personal habits, and other important associated factors. The provisional diagnosis was based on the detailed clinical history, thorough physical examination, including general examination, abdominal inspection, palpation for any obvious abdominal lump, percussion, and auscultopercussion for succussion splash, routine laboratory investigation, and some radiological investigations like plain abdominal X-ray, barium wheel X-ray of stomach and duodenum, upper GI tract endoscopy, CT scan whenever possible. Barium wheel X-ray of stomach and duodenum can detect nature and site of obstruction. The definitive treatment involves surgical relief of the gastric outlet obstruction. For benign diseases, vagotomy and enterectomy or pyloroplasty. Highly selective vagotomy and posterior gastroject are preferred. Below 2 radical partial gastrectomy remains the surgical treatment of choice, which may vary on stage and spread of disease. This is the age distribution. The result of my study is the patient of 41 to 50 years of age have maximum number of cases. In females, the incidence rate is less with 37%, in males 63%. In vegetarians, the incidence is less as compared to non-veg, 87% in non-veg and vegetarians 13%. Addiction, like smoking, tobacco, alcohol, both alcohol and smoking, and no addiction. These are the risk factors: smoking and alcohol and tobacco. These are the risk factors for gastric carcinoma. Symptoms, abdominal fullness remains the most consistent finding with 58%. And next is vomiting. After that, upper abdominal pain. Electrolyte imbalance. In benign causes, serum electrolyte disbalance is more. The percent is 73 as compared to malignant, which is 40. In chloride, 65%.
Manish, only 1 minute is left. Be fast.
Yes, ma'am. Etiology, antral carcinoma, etiology of obstruction, antral carcinoma remains the most common. In operations performed, in gastroject, anterior gastroject is anterior and posterior, it remains the 50%. Truncal vagotomy is 6%. The youngest age of patient was 15 years and the oldest 70 years, with majority being 41 to 50 years of age group. Majority of food habit is related to non-veg. In personal habit, alcohol and smoking is the cause with 28%, 26% respectively. In patient complaint, fullness remains the most common symptom. In etiology, obstruction, antral carcinoma is most common. Electrolyte imbalance is most common in benign causes than in malignant causes. In operative finding, gastroject, anterior and posterior. Anterior is 50% and posterior 20%. Anterior mostly for benign causes. Billroth remains the 15%. Discussion of 65% of antral carcinomas, 80% are male, 20% are female. 25% benign pyloric stenosis, 72% are male. and 28% are female. Incidents in male are more common than female. Abdominal fullness is most consistent. Alcohol and smoking are the risk factors.
Anish, your time is over.
Okay, ma'am.
So just tell what is your take-home message? What is your conclusion?
Ma'am, conclusion is that in most of the cases, smoking and these alcohol are the risk factors. Males are more prevalent than females, and in benign causes, anterior gastrology is most commonly done, then posterior.
Okay, now over to you, judges. You may ask questions from you.
Dr. Anish.
Yes, sir. Good morning, sir.
Can you tell me some extraluminant causes of gastric outlet obstruction?
Pseudopancreatic cyst remains the most common cause. In my case, it is 6%. 4 cases were there. It comprises 6%. Pseudopancreatic
other
cyst.
medical causes?
Any of the nodal enlargement?
Yes.
Yes, sir. Any abdominal malignancy compressing the duodenum or the stomach.
Okay, thank you.
Duodenal carcinoma, in my case, there are 2 cases of duodenal carcinoma, which also shows gastric outlet obstruction. One with bilious vomiting, one other with without bilious vomiting.
Okay, thank you.
Yes.
Do you perform anterior or posterior in benign condition, gastrojejunostomy?
Anterior, sir. In benign causes, we do anterior gastrojej.
Or posterior?
Oh, sorry, sir. Posterior gastrojej. In the malignant cases, we do anterior gastrojej.
Yeah. Okay, thank you.
Yes, sir.
Okay, thank you, Dr. Anish.
Thank you, ma'am.
Hello, Anil.
Yes, sir.
Hello.
Yes, sir.
What is the why you have done plain X-ray abdomen if you are knowing it is a gastric outlet obstruction?
Just
what
to
is
see
the role of this basic investigation in this case?
Just to see the distension of the stomach, sir. If there is gaseous shadows.
Okay.
Yes, sir. Thank you, sir.
Yes, thank you, Dr. Anish. Thank you, judges. And now I call upon our next speaker, Dr. Gaurav.
Hello, am I audible?
Gaurav, yes, you are audible. Continue.
A very good morning to the respected judges, faculty members, and my seniors. I'm Dr. Gaurav Vashish, third year DLM resident, Department of General Surgery, Tata Motors Hospital. And I'm going to present an observational study to evaluate the outcome of ureteric calculus of size 4 mm to 8 mm done at Tata Motors Hospital. Most ureteric stones of size 4 mm or less will pass either spontaneously or with medical management, but the calculus of size 8 mm or more are best managed by ureteroscopic surgeries. For ureteric calculus of size 4 mm to 8 mm, there is no consensus regarding the management, which can be either medical or surgical. Hence, we have done this study to observe and evaluate the outcome of ureteric calculus of size 4 mm to 8 mm. The lacuna in the literature are most ureteric calculus of size less than 4 will pass spontaneously. 4 to 8 mm calculus can be managed both by surgical as well as medical means, but the superiority of one over the other is not known. My primary aim is to observe and evaluate the outcome of ureteric calculus of size 4 mm to 8 mm. My primary objective is to evaluate the rate of clearance of calculus with medical and surgical modalities and the rate of conversion of medical to surgical modality. My secondary objective is to evaluate the time taken to achieve stone-free status by both the modalities and duration of pain in both the modalities. The study was done in Department of General Surgery, Tata Motors Hospital, Jamshedpur, Jharkhand. And my study population comprises of all the patients who presented with ureteric calculus in the surgical OPD and the emergency department of our hospital. It is a prospective observational study with a sample size of 162. All the patients who were included were the patients with ureteric calculus of size 4 mm to 8 mm as confirmed by CT urography and agreed to take part in my study. The excluded patients were either with less than 4 mm calculus or more than 8 mm calculus, patients who were unfit for surgery, patients refusing to undergo surgery due to any reasons, and ureteric malignancy or less than 18 years of age. CECT scan was done for the confirmation, size, position, and complications like hydroureter nephrosis, If no complications were present, then the patient was started on tab tamsulosin and increased water intake, that is more than 2.5 liters. And the patient was followed with serial X-ray KUBs on 7th, 14th, 21st, 30th, and 40th days. If the patient presented with complications like severe hydroureter nephrosis or severe pain, then the patient was posted for surgery. In surgery, ureteroscopy was done and stone was extracted with Dormier basket and with the help of a lithotripter. DJ stenting was done in all the cases, and DJ stent was removed after 28 days. If the patient on medical modality on follow-up became symptomatic with severe pain or hydroureter nephrosis, he would be converted to surgical modality of treatment. The patients were evaluated on the basis of rate of clearance of calculus with medical and surgical modalities, rate of conversion, time taken to achieve the stone, and duration of pain. These are pictures of the semi-rigid ureteroinoscope, the pneumatic lithotripter, and stone in the ureter. In my study, I had 162 patients, out of which 22 had to be posted for primary surgery. It was successful in 21 patients, and one patient failed the URS, in which we had to do an open surgery, which is a failure of surgical treatment. The primary medical treated patients were 140, which were 118 were treated successfully with medicines. 19 patients had to convert it to surgery, and 3 patients did not pass stone in 40 days and were taken as a failure of medical management. The table shows the size of stone and number of patients. Most of the patients in my study had a stone size of 4 to 6 mm, that is 51 and 49 patients respectively. Most of the patients in my study had middle or lower unitary calculus. Most of the patients presented with mild hydroureter nephrosis. As this table shows, most of the stones, that is 4 to 5 mm and 5 to 6 mm, can easily be removed with medical management, and the stones 6 to 7 and 7 to 8 mm, most of the stones can be removed with medicine, but a higher ratio required surgery. That is 7 and 12 patients in the 6 to 7 and 7 to 8 mm respectively. The rate of clearance of calculus with medical and surgical modalities is, with medical it is 118 out of 140 patients, that is 84.28%, and with surgical modality it is 40 out of 41 patients, that is a rate of 97.56%. The rate of conversion of medical to surgical modalities, 19 patients out of 140 had to be converted with a percentage of 13.57%. Now coming to the results, time for achieving stone-free state for medical patients is 11.74 plus minus 5.03 days. All 20 patients achieved stone-free status in 1 day by surgery. The mean duration of pain in medical is 2.58 plus minus 0.78 days, and surgery it was 1.38 plus minus 0.9 days. The stone clearance in my study is 84.28%, and on comparison with different studies, it is almost the same. The stone clearance by surgical modality in my study is 97.56%, which is almost equal to the other studies, but a bit higher than Mokarzil M et al., which was written in 2015. Time taken to achieve stone-free state by medical modality in my study is 11.74 plus minus 5.03 days, which is almost equal to Agrawal and P. Nuraj et al., but higher than Al Ansari et al. The limitations of my study is that catchment area is a bit small and comprises of a population from a localized region only. There is a lack of long-term outcomes, including the data on recurrence of urinary calculus. The patients, inclusion of patients with anatomical defects like ureteric stricture or malignancy will change the results, and inclusion of patients with comorbid conditions who were found unfit for the surgery and excluded from the study. If they're included, the results will change. My conclusion is, for patients who present with mild symptoms, medical expulsive therapy can be tried. Majority of calculus of size 4 mm to 8 mm can be treated with medical modality of treatment. Rate of clearance of calculus by surgical modality is higher than medical modality. Rate of failure of medical modality is higher than surgical modality. Time taken to achieve stone-free state is more in medical modality as compared to surgical modality, and pain is higher in patients who are treated with medical modality than surgical modality. The take-home message is, all the patients with ureteric calculus of size 4 mm to 8 mm should be given a trial with medical expulsive therapy. If the patient presents with severe pain or severe hydroureter nephrosis, in which case they should be treated with surgical modalities available, preferably endourological procedures. The patients who are given a trial with medical expulsive therapy should be followed up at frequent intervals to confirm the stone removal. And if on follow-up, patient is found severely symptomatic or compromised kidney functions due to severe hydroureter nephrosis, they should be taken up for surgery. Thank you. Hello.
Thank you, Dr. Gaurav. We have finished within time. Now judges are open to questions.
Dr. Gaurav, what's the time duration to be given the medicine time solution? How much long do you give?
Sir, previous studies have shown tamsulosin, if it is to remove a stone, it will remove in 35 to 37 days. My study I have given it for a period of 40 days.
40 days.
Yes, sir.
Okay. So you should continue till 40 days, tamsulosin?
Yes, sir. The previous study have shown it, if it will remove a stone, it will do so in 35 days, 35 to 37 days.
Okay. And suppose the patient is having few more stones, small stones in the kidney, then what would you suggest apart from the ureteric stone?
Sir, if the patient, sir, if he's having small stones in the surgery, in the kidney, we can observe him. If there are no complications like severe pain or obstruction, and if there's a large calculus, we can go for ESWL for the kidney stones.
Okay.
Hello, Gaurav.
Yes, sir.
Sorry,
sir. Can you please? I beg your pardon.
Okay.
Hello?
Is there any role of surgical intervention for stones less than 4 millimeter, and in which situations we should?
So if the patient is having ureteric stricture, he's less likely to pass a stone of any size. In that case, we have to intervene.
Even is the stone less than 4 millimeter?
So if the patient is
I am
having,
asking the role of surgery in case of a stone less than. Is there
yes,
any
if the patient
situation
is having,
which we can go for?
yes, sir. Sir, even if a stone of 3 mm is causing obstruction,
right,
is causing hydroureter nephrosis, or the patient is having ureteric stricture in the ureter below the stone, then sir, the stone is not going to remove with medicines. In that case, we have to do a surgery.
Okay.
Okay, thank you, Dr. Gaurav.
Thank you, ma'am.
Good presentation. Thank you, judges. And I now call upon our next speaker, Dr. Amit. Your video was visible now, but you're not visible now. Amit, unmute yourself. Yes, unmute yourself.
Yes, ma'am.
Yes, and start your presentation. Start your screen share and start your presentation. First, open your PPT. Yes. Yes, Amit, continue.
Hello. A very good morning to all teachers and faculty members. I, Dr. Amit Anand, is JR3 of Department of General Surgery under Dr. Sheetal Malwa Sir unit. Here I am going to give a presentation on an observational study on gastric outlet obstruction in young adults that got admitted in Tertiary Care Center, RIMS, Ranchi, Jharkhand. Introduction. Gastric outlet obstruction is a group of clinical and pathophysiological consequences of any disease process that produces a mechanical impediment of gastric emptying. The two most common causes of gastric outlet obstruction are as follows: gastric cancer and pyloric stenosis secondary to peptic ulceration. My aims and objective. My aim and objective are to study the various etiologies to gastric outlet obstruction in young adults. Study of various to study the various clinical presentation by the patient. Now the study of various treatment modalities and study of various treatment outcomes. Now coming to methods, my type of study is observational study. The place of study is Department of General Surgery, RIMS, Ranchi, Jharkhand. The duration of study was from July 2018 till July 2020. The study population was around 63 patients of gastric outlet obstruction who got admitted in the Department of General Surgery through emergency and outdoor. Now, inclusion and exclusion criteria was set for the patients. Inclusion criteria: all patients between 18 to 40 years of age admitted for gastric outlet obstruction were included in this study. All those patients were included who gave the consent for the study. Exclusion criteria: patients below 18 years and above 40 years of age respectively were excluded from the study. Patients who were unfit for surgery, patients who lost to follow-up. Now coming to observation and results. Age incidence. The most common age group that we found was between 29 to 40 years of age group. Around 75% of patients were found in this range. Sex
Be
incidence.
fast, Amit, okay? Otherwise, you won't be able to
Okay, ma'am.
in time.
Okay, ma'am. Males were more common than females. Incidence of presenting symptom. The most common presenting symptom was projectile non-bullous vomiting, followed by pain in upper part of the abdomen. The most common incidence of common signs. The most common sign was at the time of admission was dehydration, followed by visible peristalsis and palpable lump over the epigastrium. The etiological incidence of gastric outlet obstruction supported by histopathological examination of excised tissue. The most common was antral carcinoma, followed by pyloric stenosis or cicatrized duodenal ulcer secondary to peptic ulcer disease. Surgeries performed. The most common surgeries performed, which in our setup was subtotal distal radical gastrectomy with Roux-en-Y gastrojejunectomy. Some patients in some patients, partial distal gastrectomy with Roux-en-Y gastrojejunectomy was also done. Incidence of post-operative complication after follow-up. The most common post-operative complication that we found in our setup was anastomotic leak. It was around 7.30%. Now coming to the discussion. Antral carcinoma was the most common cause of gastric outlet obstruction, followed by pyloric stenosis or cicatrized duodenal ulcer due to peptic ulcer disease in developing countries. Majority of the patients were between 29 to 40 years of age group with male to female ratio of 2:1, which was similar to a study performed by Yogi Ram and his team and Fisher and his team. Most common presenting symptom was projectile non-bullous vomiting in 91% of cases, followed by pain in upper part of abdomen in 81% of cases, which was similar to another study by Kozol and his team and Dwarf's team. Most common presenting sign was dehydration, which was similar to the studies conducted by Abuna and Davis. Cases of antral carcinoma, subtotal distal radical gastrectomy with Roux-en-Y gastrojejunectomy was performed in 28 cases. Partial distal gastrectomy with Roux-en-Y gastrojej was performed in 20 cases. In cases of CA head of pancreas, palliative gastrojejunectomy was done in 2 cases. In cases of pyloric stenosis or cicatrized duodenal ulcer, truncal vagotomy with gastrojejunectomy was done in 5 cases. A few cases developed post-operative complication, which was managed accordingly. Now, I concluded by my study that gastric outlet obstruction is now more commonly due to antral carcinoma than stenosis in developing countries. Majority of the patients reported early after onset of symptoms, usually compelled by repeated vomiting, pain abdomen, and other features of gastric outlet obstruction. Such patients should be evaluated by lab investigation, and any electrolyte imbalance should be corrected with suitable fluid electrolytes. Early diagnosis and prompt treatment of the disease helps in reducing the post-operative morbidity and mortality. These are my references. Thank you, faculty members and teachers.
Okay, thank you, Dr. Amit. You finished in time, and now I request the judges to ask questions.
Dr. Amit.
Yes, sir.
In your series, what was the most common surgical procedures adopted for such kinds of patients in your series? Most common surgical procedures.
In my series, the most common surgical procedure that was done was subtotal distal radical gastrectomy with Roux-en-Y gastrojejunectomy.
In case of malignant.
Yes, sir. In case of malignant, because the
and in case of benign cases.
In benign cases, we have done truncal vagotomy, sir.
Truncal vagotomy. What was the recurrence rate? Truncal vagotomy. Was
The recurrence rate is almost 21%.
You have not supported truncal vagotomy with gastrojejunectomy in benign cases?
Yes, sir. I have supported. We have in some cases.
Okay.
Hello, Dr. Amit.
Yes, sir.
Where you look for vagus nerve while performing this truncal vagatomy?
Yes, sir. Sorry, sir.
Where you look for this vagus nerve? How you'll identify this vagus nerve while doing truncal vagatomy?
So first we will intraoperatively first we will remove the gastrohepatic ligament. We will remove and we will go proximally towards the esophagus.
Yes.
Yes, sir. And on the right side of the esophagus, we will identify a vagus nerve along with its branches.
How it appears, you cannot see branches there. Okay, thank you.
Yes,
okay, thank you, judges. Thank you, Amit, for your presentation. And now next speaker is Dr. Kamlesh Kumar. Yes, Kamlesh, start your screen share and start your presentation without wasting any time. Over to you, Kamlesh.
Thank you, ma'am. Okay, ma'am. Thank you, ma'am. Good morning to all of you. Myself, I will be presenting my paper on effectiveness of neoadjuvant chemotherapy in downstaging of locally advanced breast cancer in patients presented at tertiary level health center of Jharkhand. Introduction. Breast cancer is the most common cancer among Indian women. Because of low literacy of the state and lack of awareness about the disease, patients of breast cancer usually present at later stage. In the management of locally advanced breast cancer, surgery is integrated with chemotherapy and radiotherapy to provide optimal local regional disease-free survival as well as distant disease-free survival of the patient. The neoadjuvant approach offers the advantage of downstaging the disease, potentially reducing the extent of surgery, and in the era of individualization of therapy, testing the efficacy of therapy administered to the patient. Aims and objective of my study is to assess the effectiveness of neoadjuvant chemotherapy in downstaging of locally advanced breast cancer. Materials and method. Between January 2019 to January 2020, total 30 patients with locally advanced breast cancer who completed total 4 cycles of neoadjuvant chemotherapy was included in this study. Inclusion criteria. Patients with breast cancer stage 3A who completed 4 cycles of neoadjuvant chemotherapy. And exclusion criteria who do not completed 4 cycles of neoadjuvant chemotherapy, and inflammatory breast carcinoma is also not included in the study. All baseline evaluation are done within 4 weeks of beginning of the neoadjuvant chemotherapy. The size of the breast tumor is measured by MRI. The 4 cycle of neoadjuvant chemotherapy, the CAF regimen is given to the patient at 21 days interval. The efficacy of neoadjuvant treatment is assessed by evaluating the clinical and radiological response during and after therapy. The radiological response is assessed by response evaluation criteria in solid tumor version 1.1. Dose of CAF regimen is cyclophosphamide for 500 mg per unit body surface area in meter square, adriamycin 50 mg per meter square, and 5-fluorouracil 500 mg per meter square. And before starting neoadjuvant chemotherapy, longest axis of non-nodal lesion and short axis of nodal lesion are added and reported as the baseline sum diameter of the target lesion. After the completion of neoadjuvant chemotherapy, again sum diameter of the target lesion measured by adding longest diameter of non-nodal lesion and short axis of the nodal lesion. Then change target lesion calculated and classified as complete responder, partial responder, progressive disease, and stable disease, as shown in the next slide. This is the spectrum of the response to neoadjuvant chemotherapy in breast cancer. The complete responder are the patient in which all target lesions disappears, and any pathological lymph node must have reduction in short axis to less than 10 mm. The partial responder more than equal to 30% increase in the longest diameter of the target lesion. Progressive disease more than equal to 20% increase in the longest diameter of the target lesion and appearance of new lesion. And the stable disease neither sufficient shrinkage to the classify as partial responder nor sufficient increase to classify as progressive disease. Observation and discussion. The age range of the patients with locally advanced breast cancer enrolled in the study was 39 to 62 years. Mean age was 46.7 to plus minus 5 to 2 years. The largest tumor size was 8.2 centimeter and the smallest tumor size was 4.2 centimeter. Out of 30 patients enrolled in the study, 22 patients showed partial response, that is more than equal to 30% reduction in the primary tumor size, and 8 patients showed no response to neoadjuvant chemotherapy, that is the stable disease. And decrease in tumor size by KF regimen is more in patients with HER2 negative tumor. Observation. MRI of the breast. This picture shows MRI of the breast before starting neoadjuvant chemotherapy, and this is after completion of 4 cycles of neoadjuvant chemotherapy. We can see this. We can see in the picture that the reduction in the size is more than 30%. So this patient shows partial response. Conclusion. Due to low literacy and lack of awareness about the disease, many patients of the carcinoma of the breast present to the health care facilities in locally advanced stage of the cancer. Neoadjuvant chemotherapy is a valuable clinical and research tool with great potential in patients with locally advanced breast cancer. Neoadjuvant chemotherapy may convert a previously unresectable locally advanced breast cancer to an operable tumor. In locally advanced breast cancer, neoadjuvant chemotherapy may downstage tumor to permit breast conserving surgery rather than mastectomy, improving cosmetic outcome. But in some patients, the decrease in size of the tumor is less than 30%. So these patients, in these patients, disease was stable. And this is the treatment protocol we followed after the completion of neoadjuvant chemotherapy, taken from Schwarz Principle of Surgery, 10th edition. This is the reference. And thank you.
Thank you, Dr. Kamlesh. Finished within time, and now judges can ask questions.
Yes, Dr. Kamlesh.
Okay, ma'am. Yes, sir.
Dr. Kamlesh.
Yes, sir.
Hello.
हाँ सर मैं सुन रहा हूँ.
Kamlesh is out of. Hello, Dr. Kamlesh.
हाँ सर मैं
Am I audible to you?
Yes, sir.
अच्छा, just one sentence. If after receiving neoadjuvant chemotherapy,
yes,
the tumor has completely disappeared. So in that case, you go for mastectomy or not?
Yes, sir. We will go for mastectomy, sir. उसके बाद भी सर्जरी करेंगे सर हम लोग.
Why?
सर मे भी पैथोलॉजिकल कंप्लीट रिस्पॉन्स नहीं हुआ हो, उसमें सेल्स अभी कुछ ट्यूमर सेल्स प्रेजेंट हो सकते हैं सर. तो सर मैं मास्टेक्टोमी करके पैथोलॉजिस्ट के पास.
इसमें मास्टेक्टोमी और रेडिकल मास्टेक्टोमी, which kind of simple mastectomy or radical MRM?
नो सर, मैं सर सिंपल मास्टेक्टोमी करूंगा और एक्सिलरी लिम्फ नोड का असेसमेंट करूंगा सर.
नहीं, in case of LABC, locally advanced breast cancer, I am talking about locally advanced breast cancer. The patient received neoadjuvant chemotherapy and the tumor has completely disappeared. Would you go for MRM or mastectomy?
सर पेशेंट का मैं फिर से स्टेजिंग करूंगा आफ्टर कंप्लीशन ऑफ द neoadjuvant chemotherapy. अगर पेशेंट स्टेज 2 में चला गया होगा तो मैं सिंपल मास्टेक्टोमी करके सर एक्सिलरी लिम्फ नोड का केवल असेसमेंट करूंगा. अगर पेशेंट अभी भी स्टेज 3 में होगा तो सर मैं मॉडिफाइड रेडिकल मास्टेक्टोमी करूंगा.
ओके.
वाईफाई से डिस्कनेक्ट कर दो. कमलेश.
Yes, sir.
Disconnect कर देते. How do you categorize this locally advanced breast cancer? What are the criteria?
Sir, TNM according on the basis of TNM, tumor size, nodal stages and metastasis के according उसके मैं सर 3A, 3B और 3C में classify.
You are saying locally. No, you are saying locally advanced breast cancer. We are not talking about metastasis. Locally advanced breast cancer. How do you categorize?
On the basis of tumor size and nodal stages, sir.
Dr. Kamlesh, is there any tumor size which you consider for going to MRM or simple mastectomy?
No, sir. We will go for whether mastectomy or according to the stage of the tumor. Stage 1, 2, 3, and 4, not according to the size of the tumor, sir.
Okay.
Okay, thank you, judges. Thank you, Dr. Kamlesh.
Okay, thank you.
And now I call upon our next speaker, Dr. Manoj Kumar Das. Yeah, Manoj, just open your PPT and start your presentation.
No
Start your
internet.
Manoj, start your screen share. Is there any problem? So there's something wrong with Manoj. So shall I move on to our next speaker? Are you ready, Yusuf?
Yes, ma'am. Am I audible?
Yes, you are audible. Now you start your presentation. Okay, you start your screen share and start your presentation.
Okay.
Okay, Manoj will present after you.
So my topic is the comparative study of various surgical modalities done for sigmoid volvulus in a tertiary care center in Ranchi. My guide for this case series was Dr. Arun Kumar Tiwari, Associate Professor, Ranchi, RIMS, and Professor Dr. R. Sharma. Volvulus is an abnormal twisting of the bowel on its mesenteric axis, which is greater than 180 degrees, which produces an obstruction of the intestinal lumen and mesenteric vessels. Sigmoid volvulus is a surgical emergency causing large bowel obstruction with high mortality and morbidity. Patient may present with features of shock, generalized abdominal tenderness, and peritonitis. This condition is life-threatening if emergency procedures is not done. This study analyzes management options in our institute and its results. The etiology for volvulus has been attributed to high fiber diet in certain populations, although it also occurs in elderly patients who are on low residue diet, especially those excessively using laxatives. Other contributory factors are adhesive bands, megacolon, pregnancy, and Chagas disease. It is in our study, it was found to be more common in males, and it is because due to large volume of female pelvis, which facilitates spontaneous untwisting of the volvulus. Patient presents with obstipation, marked abdominal distension, nausea, and vomiting. Vomiting preceding or coinciding with the onset of abdominal signs may be a predictor of increased morbidity and mortality. In delayed presentation, the patient may also present with features of shock. Generalized abdominal tenderness and peritonitis point towards the presence of an underlying gangrenous segment in the sigmoid volvulus. Now we're coming to materials and methods. This case study includes all the patients presenting in emergency department with sigmoid volvulus. The inclusion criteria was patients admitted with the clinical diagnosis of sigmoid volvulus and who underwent surgical procedures during the study period. Patients who were excluded were causes of large bowel obstruction other than sigmoid volvulus, and those patients of sigmoid volvulus who were relieved by conservative management, that is flatus tube insertion, nasogastric tube insertion, sigmoidoscope or colonoscopic reduction. These patients were excluded from the study. Patients presenting to emergency department with clinical features of large bowel obstruction were admitted and evaluated. Resuscitation was done according to their vital status. A detailed history was obtained and a clinical examination was done. Patients with suspicion of sigmoid volvulus were further evaluated. History of presenting illness, past illness related to bowel disorders, diet and bowel habits. A plain X-ray of abdomen in erect posture was taken and a chest X-ray PAV was done. This confirmed the diagnosis of sigmoid volvulus in most instances preoperatively. The highly distended omega loop or the coffee bean sign on X-ray could be demonstrated in most of the cases. Patients with subacute presentation and non-diagnostic X-ray abdomen were further evaluated by USG and CT abdomen. Now, this is the film showing the classic coffee bean sign in patients with sigmoid volvulus on X-ray. And now coming to operative procedures such as sigmoidopexy, mesocoloplasty, resection of colon with primary anastomosis, resection and anastomosis with divergent colostomy, and Hartmann procedure where the procedure is undertaken. The procedures done were decided on the basis of general condition, hemodynamic status of the patient, and intraoperative findings. Postoperatively, patients were monitored in the wards. Patients with divergent stoma were followed up for colostomy closure after 12 weeks. So this is the image showing the procedure of mesocoloplasty that was being done. Now we're coming to results. Total of 26 cases of sigmoid volvulus who underwent surgical treatment were included in the study. The maximum of the patients were between the 3rd and the 6th decade. A maximum number of patients were male, 18 males and 8 females in our study. Now, on the basis of intraoperative findings, the procedures were done, like in patients there in which there was not there was viable bowel and not grossly distended sigmoid. Procedures such as sigmoidopexy and mesocoloplasty were undertaken, and such patients in which the bowel was gangrenous and according to the hemodynamic stability and general condition of the patient, procedures such as RA or diversion or Hartman procedure was undertaken. There was no mortality in patients who undergone sigmoidopexy or mesocoloplasty. There was one mortality in each group with RA with diversion and Hartman procedure. Wound infection was most common post-operative complication in our case. 2 patients who underwent resection and anastomosis had anastomotic leak. Mean hospital duration stay was less in patients with the sigmoidopexy or mesocoloplasty, and with patients with RA and Hartman procedure, it was a little more. Now we're coming to discussion. Sigmoid volvulus is a surgical emergency causing large bowel obstruction. Clinical presentation may be acute or subacute. Acute subtype is characterized by a sudden onset abdominal pain, vomiting, abdominal tenderness, obstipation. Gangrene usually develops early and leading to fecal peritonitis and septicemic shock. Subacute form is characterized by an insidious onset and progression and frequently occurs in older patients. Almost all the cases could be diagnosed with clinical neurological examination and confirmed by intra-op findings. Most of the time, with an X-ray abdomen alone, we were able to make a preoperative diagnosis. Now we're coming to conclusion. There is no ideal surgical procedure which can be generalized for sigmoid volvulus, but procedures like mesocoloplasty has a slight more advantage over sigmoidopexy in terms of recurrence. Though these procedures are associated with less duration of hospital stays, they cannot be performed in a gangrenous or a grossly dilated bowel. Resection and anastomosis is better than resection with diversion only if general condition of patient is good preoperatively, otherwise it can lead to anastomotic leak. Patients who were hemodynamically stable with poor general condition are intraoperatively found to have a grossly dilated bowel with gangrenous changes, and where exact line of demarcation could not be established, there was resection done for the doubtful segment, followed by end-to-end anastomosis with a divergent stoma. Divergent colostomy provided ample time for healing of anastomosis, and it also enabled us to start early enteral feeding, leading to better nutrition and post-operative recovery.
You're running out of time, Yusuf. Finish.
In patients with poor general condition, hemodynamic instability, with gangrenous bowel intraoperatively, Hartman procedure was the procedure of choice. Wound infection rates are high, especially in amputated bowel. Now,
judges can ask questions. Vibhas sir, unmute yourself to ask questions.
Hello.
Yes, sir. Yes, sir.
When you'll perform primary colectomy with re-enter anastomosis, in what are the cases where, I mean, gangrenous, or in all other cases where even with the large mesentery also you are doing primary colectomy, or only in gangrenous ones?
So if the patient is hemodynamically stable or patient is in good general condition, we can go for a colectomy with the primary anastomosis. There would not be any need for diversion in that, in those group of patients. Otherwise, it can lead to anastomotic leak, as we have seen.
And PEXI?
And sigmoidal PEXI is basically preferred in old patients who are not suitable candidates for a primary anastomosis. So in those patients, we can do a sigmoidal PEXI. It can lead to recurrence, sir, but in such patients, it could be done.
Yes. Okay, thank you.
Thank you, sir.
Hello, Mr. Yusuf.
Yes, sir.
So what is the post-operative complications in your series?
According to the procedure done, the most common post-operative complication was wound infection in patients who had undergone resection anastomosis. It was, in our case, I think it was due to poor bowel preparation in those patients, and it was also due to poor nutritional status of those patients.
Surgery related post-operative, not the general complication. You had
in sir, sigmoidal PEXI, out of 4 patients, 2 patients had recurrence. That was in those cases, and out of 10 patients in which resection anastomosis with no diversion, 2 patients had anastomotic leaks.
So what is the take-home message for sigmoid volvulus in your case, in your studies?
In my study is that, sir, there is no ideal procedure that can be generalized for all, that can cover all the causes of sigmoid. The intraoperative findings are the most common factor which can determine what type of procedures should be undertaken.
Okay, now thank you, Dr. Yusuf. I'll have to stop here because the discussion time is over. And now Dr. Manoj will be presenting because he had a technical glitch earlier. Dr. Manoj, are you ready?
Ma'am, yes, ma'am.
Now start your screen share. Open your PPT. Start your screen share. Yes.
Good morning, sir. I will be presenting observational study of temporary stoma in prevention of anastomotic leak. Introduction. A gastrointestinal stoma is an artificial opening in gut brought out through the abdominal wall to divert the gastrointestinal secretions and waste product to the exterior. Anastomotic leakage is defined as a communication between the intra and extra luminal compartment owing to a defect in the integrity of the intestinal wall at the anastomosis. Aims and objectives. Our aim is to comparative usefulness of this technique as compared to intestinal anastomosis not protected by temporary stoma. Material. This prospective study included 86 cases with acute intestinal obstruction and traumatic perforation in which resection and anastomosis with or without stoma was done in Department of Surgery from March 2019 to February 2020. The method of study included clinical, pathological, radiological, and endoscopic examination followed by closure of a small intestinal stoma. Results: a total 86 cases done in which age group distribution. Most of the cases are found in 31 to 50 age group. 6 out of total 86 gastrointestinal anastomy, 51 cases were performed for volvulus, 22 for trauma, 10 for band adhesion, and 3 for malignancy. The mean age of the patients was 63.7 years, ranging between 18 and 80 years, and sex ratio of 2.9:1 with male to female was found. The most frequent comorbid factors are cardiovascular disease and followed by diabetes, mellitus, and obesity. Deep functioning stoma were performed in only 52 cases, 60% of all. Resection and anastomosis done in total 34 cases, and in the resection anastomosis with stoma were done in 56 cases, 52 cases. The overall mortality rate was 3.4%. One case mortality resulted from anastomotic dehiscence with conjugative sepsis. Although re-intervention was performed as soon as signs of leakage occurred and a terminal colostomy was performed at re-intervention, the patient died from associated cardiovascular disease with sepsis. Leak occurs in total 4 patients and no leak occurs in 30 patients. Symptomatic post-operative anastomosis leak occur in 4 patients. None of these had a deep functioning ileostomy and one of them had a fatal outcome. 2 patients with mechanical anastomosis between 6 and 8 cm from anal verge had a favorable evaluation of the leakage under conservative treatment in association with an efficient proximity drainage tube. We must recognize that none of the 52 patients with protective stoma developed asymptomatic anastomotic fistula. However, we encountered some important complications related to ileostomy, represented in one case by periostomal cellulitis and in other case by intense dehydration with fatal outcome in a patient with cardiac insufficiency. The overall mean duration of hospitalization was 12.4 days, average 5 to 35 days, and duration was higher in patient with ileostomy. This anastomotic leakage involves an imperfection at the site of anastomotic line between two hollow organs. This imperfection results in communication between the intraluminal and extraluminal space through which the contents of the hollow organ can leak out and which can have clinical manifestations such as general or localized peritonitis and abscess. In 2010, Rahbari and proposed the following classification of anastomotic fistula. Grade A fistula, those that do not require any change in patient management. Grade B fistula, those that require a change in patient management but do not require re-laparotomy. Grade C fistula, those that require re-laparotomy. The incidence of anastomotic fistula reported by different authors varies widely from 0 to 28%. Such large differences are difficult to explain. The low incidence of anastomotic fistula, only 3% found in our study, leads to believe us that deep functioning stoma formation is not necessary in cases without obvious risk factor and when the general population of a good anastomosis are followed. It is well known that a deep functioning stoma does not prevent anastomotic dehiscence, but it can prevent the serious consequences of the conjugative peritonitis. That means first category include authors of a Swedish multi-center randomized trials published in 2007 with 234 patients. These authors found an anastomotic fistula rate of 28% for anastomosis without a protective stoma and 10.3% for anastomosis with a protective stoma. Considering the high incidence of fistula, the authors justifiably recommend the use of stoma in all cases. The authors in second group based their recommendation on meta-analysis of studies published by other authors. In our study, stoma was performed. We only selected cases based on the fact that ileostomy is not free of complications. In our study, maximum laparotomy was male patient with. Therefore, creation of a temporary stoma should be considered in all cases, in cases of gastrointestinal anastomosis. These are my references. Thank you, sir.
Thank you, Dr. Manoj. Now judges can ask questions.
Yes, ma'am. Yes, sir.
Dr. Manoj, can you tell any other indication for stoma formation apart from the conditions you told?
If gangrenous bowel and patient more conditions, nutritional build, FH build with poor, it's in cases where ileocecal tuberculosis, malignancy, stoma.
Your voice is not coming.
Yes, sir.
Couldn't hear you.
Yes, sir. Repeat, sir.
Please repeat your answer. Yes.
Yes, sir. In cases where gangrenous bowel, ileocecal tuberculosis, malignancy, and in that
It's all right. We are losing the links.
Dr. Manoj, hello.
Yes, sir.
Yes, I'm Dr. Ziaullah. Just my one question is, you are telling in all cases of GI anastomosis, one should go for defining ileostomy. How much it is relevant? How can you say in all cases? Just you have presented.
No, sir. In all.
No, in all cases, just
No,
your
sir.
last slide. I've shown in all cases. So I don't think this is the indication for protective ileostomy in all cases, irrespective
No,
of the
sir.
nature of the
Actually,
disease and the general condition of the
No, sir.
patients are. So I think it is not relevant. Anna.
Not, sir.
You are telling in all cases, protective ileostomy should be considered. Is it?
No,
Right.
sir. Yes,
So what
No.
are those situations? You just mentioned those situations.
Where gangrenous bowel, and
We
nutritional
are doing anastomosis mostly for the gangrenous bowel. This is not the indication. We are doing anastomosis for the gangrenous bowel most of the times. So you are creating a confusion.
Not in almost
Dr.
all
Manoj,
cases. Yes, sir.
have you compared the two groups where regarding the anastomotic leak, in one group where the stoma was created and the other group where the stoma was not created? Did you do
Yes,
a
sir.
comparison?
Yes, sir. In
Then you
our
will be able
study,
to say how.
in our study, sir, 52 cases are having resection and anastomosis with stoma done, in which there is no leak found, and 34 cases where only resection and anastomosis without stoma done, where 4 leaks were found.
Okay, I'm sorry here to interrupt. We are running out of time. So I request judges to stop now and we move on to our next presentation. Dr. Arun Mozi, yes? Say something? Yes, now start your screen share and start your presentation. Open your PPTs, start your screen share.
Am I audible, ma'am?
Yes, you are audible. Start.
Good morning, everyone. I'm going to present a topic on step-up of procedure and its outcomes in case of acute necrotizing pancreatitis. And my guide is Dr. Anjay Kumar, Associate Professor of Surgery, Department of General Surgery, RIMS Ranchi. Introduction. Acute necrotizing pancreatitis continues to be one of the difficult conditions to be treated. Many surgeons. Pancreatic necrosectomy carries a high mortality rate, which usually occurs in the immediate post-operative period. So still the decision for whether to operate or not in case of acute necrotizing pancreatitis is still a dilemma, as the mortality is high and which usually occurs in the immediate post-operative period and carries a high medico-legal. In the medico-legal perspective, it's still a confusion. Patients and methods. This is an observational case series analysis study done in the Department of General Surgery, RIMS Ranchi. And the study group includes 5 patients of age group belonging to 30 to 50 years. All the patients, 5 patients came to us, came to the emergency room with severe abdominal pain and diagnosed to be severe acute necrotizing pancreatitis and evaluated for the same. Done, which contrast enhanced CT done, which was showing a severe necrosis pancreas with fluid collection, which were infected fluid collections were found, and the serum amylase, lipase, and other biochemical parameters were deranged. Treatment done was initially US guided aspiration of the pus and collection around the pancreas was done. In some patients, the repeat procedures were also were necessary and followed by pictal catheterization. After a few days, if there is present and the catheter was continuously draining the infected material, and after few days, if there is presence of any residual infective collections, then exploratory laparotomy with necrosectomy was done. In the meantime, patient was kept initially nil per oral and well hydrated with IV fluids. IV antibiotics were given, analgesics were given, and patients who were kept nil per oral for a prolonged time were given total parenteral nutrition, and whenever possible, earlier Ryle's tube belonging to the age group third rotating pancreatitis with CT severe. In the procedure done in all the patients were ultrasound guided aspiration followed by pigtail catheterization, and in 2 patients repeat aspiration was also done, and after surgery was done in all the patients with post-operative period was uneven full and we lost one patient and the patients were followed up for 6 months and only mild symptoms. This is a CCT image of a patient showing severe necrotizing pancreatitis with air pockets suggesting infective collection in the peripancreatic region, mostly in the lesser sac area. Infected collection were continuously drained by the pigtail catheter. Results: out of the 5 patients, 4 patients recovered from the disease and discharged successfully. Average hospital stay was 15 to 20 days. 1 patient expired after the surgical procedure. No significant complaints in the average follow-up period of 6 months. All the biochemical parameters were within normal limits in the follow-up period. Discussion: due to the profound inflammatory response, which is already present in cases of acute necrotizing pancreatitis, surgery is challenging in these cases, as this may further exacerbate the inflammatory situation. A more conservative approach improves outcomes whenever possible. This includes using antibiotic, delaying the interventions, starting with less invasive interventional strategies when possible, and upgrading as necessary. A minimally invasive step-up approach, as compared with open necrosectomy, reduces the rate of composite endpoint of major complications or death among patients with necrotizing pancreatitis and infected necrotic tissue. The following are proposed as possible explanations supporting the step-up approach. Infected necrosis may be similar to an abscess because both contain infected fluid and which is pus under pressure, which has to be drained. And if it is drained, gives a good relief of symptoms. It has been suggested that a minimally invasive technique provides less surgical trauma in patients who are already severely ill. This hypothesis is supported by the substantial reduction in the incidence of new onset multiple organ failure in our step-up group. The step-up approach is the current standard of care in patients having infected pancreatic necrosis. Minimally pancreatic necrosis. In some cases, due to the absence of abscess, due to the presence of abscess or extensive necrosis of pancreas, step-up procedure proves to be the better in terms of outcome compared to direct surgery, as it reduces the infective load and nutritional and biochemical factors of the patient can be improved in the meantime. Thank you.
Okay, thank you. Dr. Arun Modi, now the judges can ask questions.
Dr. Arunmoji,
Yes, sir.
how you approach for in the case of minimal access? How you approach that for a necrosectomy?
Sir, we usually there are two approaches, sir. It can be approached through intraperitoneal or retroperitoneal approach, sir. It depends. Our approach depends upon the site of the collection and overlying structures like bowel, and we are used to approach with minimal, no injury to the bowel.
Yes. And in case of open approach, open.
Sir, open necrosectomy is done through midline laparotomy and lesser sac. Usually collections are present in the lesser sac. The lesser sac can be opened through the gastrocolic, opening the gastrocolic omentum.
Okay, thank you.
Dr. Burman.
Yes, sir.
What is the ideal time for surgical intervention in case of pancreatic necrosis? When you should go for pancreatic necrosectomy in case of severe acute pancreatitis?
Sir, in case of severe acute pancreatitis, patients, if continuously they are not improving after minimally conservative approaches, surgery could be done, sir, which is usually done after 1 to 2 weeks, sir.
1 to 2 weeks. Or other criteria?
Sir,
timing, apart from timing.
Apart from timing, if there is patient has due to the presence of necrosis, if there is a continuous elevation of the WBC counts, presence of the fever, and if the patient is going to if initially has some systemic inflammatory response syndrome and it is not becoming normal after conservative approaches, you have to go for surgery, sir.
Thank you.
Okay, thank you, judges. We are running out of time. 2 minutes are over for discussion. So we move on to our next presenter, Dr. Pallavit Sahai. Pallavit, say something.
Yes, ma'am.
Yes, you start your screen share and
yes,
start.
ma'am. Am I audible, ma'am?
Yes, you are audible.
Hello.
Yes, you are audible, Pallavit. Open your PPT and yes.
Okay. Yes, ma'am. Okay, ma'am.
Open your PPT. Your PPT slide is not visible yet. Yes, start. Start, Pallavit.
Ma'am, I have shared my slide. I'm Pallavit and my guide is Professor Dr. R.S. Sharma, sir. My topic is comparative tomography score as a prognostic tool in acute pancreatitis, which can be applied in rural healthcare settings. Coming to the introduction, acute pancreatitis is supportive care to severe disease with multiple organ failure and high mortality. Although most patients experience minor episodes characterized by mild and the response to conservative management and approximately 20 to 25% of patients develop clinically severe acute may progress to pancreatic necrosis,
Only your first slide is visible,
syndrome, multi-organ failure, clinical deterioration.
Yes. Okay, continue.
Ma'am, I have okay, ma'am. So historically, mortality has been in the setting of necrotizing pancreatitis as 30% infected pancreatic necrosis. CT is particularly useful in its ability to demonstrate pancreatic necrosis from a baseline to 40 ounces per unit, which is in viable pancreas, it enhances by more than 50 Hounsfield units with IV contrast. Detection, CT guided aspiration is 96% and 99% respectively, with positive predictive value of 99.5 and negative value of 90%, and extra pancreatic inflammation with the extent of pancreatic necrosis. In 2004, a modified CTSI was designed and it accounted to overcome several potential limitations of CTSI. MCTSI incorporates pancreatitis in the assessment and simplifies the evaluation of extent of pancreatic parenchyma into none less than equal to 30, peripancreatic inflammation denoting whether it is present or absence of peripancreatic fluid collection. Systemic complications we have to take into consideration of SIRS or systemic inflammatory response syndrome, which comprises of 4 criteria, which heart rate more than 90 per minute, core body temperature more than 38 or less than 36, respiratory rate of more than 20 per minute, or partial pressure of carbon dioxide less than 32 millimeter of mercury, leukocyte count of more than 12,000 cells or less than 4C. Other important systemic complications which has to be taken into includes multiple organ dysfunction, which defined as presence of altered organ dysfunction in a severely ill patient, such as hemostasis can be attained without intervention. Includes atelectasis, pleural effusion, pneumonia has to be taken into consideration. Now, QSOFA or Quick Sepsis Related Organ Failure Assessment Score is based on rapidly accessible vital parameters including fast rapid respiratory rate, altered mental status, and low blood pressure. It is critical to validate the score in subgroups of severely ill patients, and the primary aim of this study is to evaluate the predictive performance of QSOFA in patients of acute pancreatitis and compare it MCTS. 3 important categories: pancreatic inflammation, pancreatic necrosis, and extra pancreatic complications, and points are allotted according to it and categorized into mild, moderate, and severe. Severe is when the score is more than equal to 8. Coming to QSOFA, it has 3 indices. Systolic arterial beat is less than equal to 100 millimeter of mercury. Respiratory rate when it's more than equal to 20 per minute, and mental status that Glasgow Coma scale is than 15, and aim and objective early diagnosis and determine acute pancreatitis to reduce the overall mortality and morbidity. The aim of this study is to analyze the correlation of QSOFA with overall prognosis so that early evaluation of patient and its comparison can be done in rural healthcare setting. Materials and methods. My type of study was observational case series.
Okay, I think he lost his connectivity. So what to do, judges? Should we move on to another next?
Hello.
Or should we? Pallavit, what happened? Can you please go there from where you started left?
Ma'am, I think connection. Yes, ma'am.
Can
Yes,
you
ma'am.
finish your presentation?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes.
Ma'am, is it visible? Ma'am, can I continue?
Yeah, now
Hello.
it's all right. Yeah, continue.
Okay, sir, I'm continuing. Okay, thank you, sir. All patients underwent CT scan of the whole abdomen, which were diagnosed as acute pancreatitis and were severely ill, and QSOFA parameters, respiratory rate, coma scale, and system. Hello. Hello. Sir, is it audible?
Not very clear. Not
Hello.
very clear.
Hello.
It's
Sir, is
not,
it audible?
not very clear.
Hello.
Pallavi, yes, you are audible. Just continue. Actually, in the background, there is some noise.
Hello.
Pallavi, in your background, there is
Okay,
some
ma'am.
noise.
Results of my study were. Yes, ma'am.
Yes, yes, continue, continue.
Results of my study was in the patients with MCTSS score more than equal to 8 out of 30. 12 patients were severely morbid. Ma'am, am I audible?
Yes, you are
Hello.
audible. Please continue.
Hello.
Pallavi, please continue. You are audible.
Thank you, ma'am. And Q-SOFA score with more than equal. Yes, ma'am. Q-SOFA score of more than equal to out of 30 patients, 14 were having severe morbidity with mortality in 12 patients. There was patients out of 12, there was 10 were having systemic complications and surgical management was required in 2. With comparing with score, all systemic complications were seen in this out of 14. This was the age.
So finish. You are going.
Distribution.
Finish in 30 seconds. Finish in 30 seconds.
Predominantly involving age group of 20 to 50 years. Sex distribution was, ma'am, 27:3. City of showing rising pattern. Coming to discussion and comparing with the Q so far, results were observed to be almost equivalent. This Q so far can be utilized as an early prognostic tool in rural healthcare centers where there is paucity of CT scan to categorize the patient on the basis of severity of illness, and this bedside tool can be help in early detection of severity of illness so that patient, if requires an ICU support, intensive care support, can urgently be referred to a tertiary care center from a rural healthcare setting. Thank you. Thank you, sir.
Yes, the judges are now open to questions.
Dr. Pallavi, there was some technical problem. We couldn't hear you clearly. But do you use Ranson's criteria scoring system to evaluate?
Yes, sir. Ranson's criteria. Yes, sir. Yes, sir. Yes, sir. Ranson's criteria is used within 48 hours, but in rural healthcare setting, in primary healthcare center, if the patient comes immediately and blood really does not require any blood investigations, at the time of admission only we can measure, sir, GCS, respiratory rate. So immediate, sir, action can be taken. If a patient comes with pancreatic necrosis, transfer the patient to ICU care settings. So that was the purpose, sir. Where CT is available, we can then manage the patient.
Okay, thank you.
Thank you, sir. Thank you, sir.
Pallavi, why there is so many scoring system for pancreatitis? Exactly.
So pancreatitis is a life-threatening. Yes, sir. So yes, sir. Pancreatitis is a life-threatening complication. We have to evaluate, monitor the patient continuously to prevent complication. So there is abnormal electrolyte abnormalities. Sir, we have to monitor each and every parameters quite closely. So saturation also drops. So Ranson's prognostic criteria takes into consideration saturation, serum calcium levels. Sir, bedside evaluation is also required. So, sir, prognostic indicators is present in pancreatitis.
It affects a lot of systems. So
Systems,
you need
yes, sir.
to assess all those
systems. All the systems, yes, sir. Yes.
You have to include all those criteria for your assessment or scoring.
Yes.
So that's why there is so many
Yeah.
scoring systems are there. Okay, thank you.
Yes, sir. Yes. Thank you, sir. Thank you, sir.
Okay, thank you, judges. Thank you, Dr. Pallavit. Now we move on to our next presentation.
Thank you.
Dr. Krishnan Kumar will be presenting it. Okay, now you open your PPT and start your screen sharing. Dr. Krishnan Kumar.
Yes, ma'am.
Open your PPT first and then start screen sharing. Yes. Yeah, continue. Start from the first page. First slide. Yes.
Good morning, sir. Sir, I am presenting. I am Dr. Krishnan Kumar, GRE3 of RIMS Ranchi. My guide is Dr. Sital Malwa. Sir, my topic is sarcoma overview on different clinical presentation at the RIMS Ranchi. The introduction: the sarcoma occurs in 2 to 4 people per lakh population, and it has more than 50 subtypes. There are 3 principal kind of sarcoma corresponding to different clinico-etiological entity with individually specific progression and specifically different management study. One sarcoma, visceral sarcoma, and develop in the specific organ, most typically being GIST, and soft tissue sarcoma arising connective tissue and extra-osseous connective tissue, and these are represent about 1% of the adult cancers. Soft tissue sarcoma are the rare heterogeneous group of the tumors arising in connective tissue and embryologically derived from the mesenchyme. There are many subtypes arising from the cartilage, muscle, blood, vessels, nerves, and the fat. Based on the current WHO classification, there are now more than 50 different distinct subtypes of the soft tissue sarcoma. There are may develop at any age, including a childhood, can occur anywhere anatomically from head to foot, and varying aggressiveness and even within the same histological subtype. The bone sarcoma to soft tissue sarcoma incidence ratio 1:4. There is great male predominance of the 1.4 is equal to 1 in male to female ratio in soft tissue sarcoma. The median age of diagnosis is 59 years. There bimodal distribution of soft tissue sarcoma peaking in the 5th and 8th decade. Soft tissue sarcoma most commonly occur in the extremity, which is about 40% of all soft tissue sarcoma, predominantly in the lower limb 28% versus the upper limb 12%. The thigh is the most common site in the body, account for 44% of all the extremity soft tissue sarcoma. The second largest group of sarcoma is the bone sarcoma or the bone cancer. There are 3 types of the bone sarcoma: osteosarcoma, Ewing sarcoma, and chondrosarcoma. There is other entity, the visceral sarcoma or intra-abdominal sarcoma, that tend to involve any visceral organ in the abdominal cavity with the predilection of gastrointestinal tract. Histopathologically, gastrointestinal stromal tumor and the leiomyosarcoma are the most frequent subtype of the visceral sarcoma. Visceral sarcoma are the rare. Their etiology unknown and clinical presentation may vary from case to case. Diagnosis can be suspected on the ultrasound, CT, MRI, however, exploratory laparotomy with the histopathological examination necessary for the confirmation. Our aim or objective of our study to know the different clinical presentation of different forms of sarcoma, site, different types, surgical excision, and effect of chemoradiotherapy. Material method: the study type is prospective case study. Study population 20 patient of our indoor patient admitted in RIMS Ranchi, our Department of General Surgery. Study duration 2 years. Place of study is indoor patient admitted in Department of Surgery. Plan of analyzing data: the patient present mostly from painless lump in a different part of body, mainly extremity. Diagnosis was done by FNSC or CT scan or MRI and core needle biopsy. Discussion: there is classical presentation of the soft tissue sarcoma is that of painless enlarging lump. The growth rate of sarcoma is variable and can be rapid and slow. The soft tissue lump show any of the following clinical features are to be considered to malignant until otherwise proved. The increase in size more than 5 cm, deep seated, or the painful. The greater the number of these clinical features, bring the present and greater the risk of soft tissue mass being malignancy, with the increasing the size being the best individual indicator. Based on the current WHO classification, most aggressive soft tissue sarcoma is liposarcoma, leiomyosarcoma, and undifferentiated pileosarcoma. Previously, it is known as malignant fibrous histiocytoma. Here, one case I will seeing the tumor over left thigh. As here, MRI of this patient showing the tumor. Soft tissue sarcoma diagnosed basically on the imaging and tissue biopsy. Imaging mainly CT, MRI, ultrasound. The core needle biopsy is a biopsy modality of the choice in the most of sarcoma. Occasionally, if the core biopsy is non-diagnostic, in which case is incisional biopsy is necessary. The treatment of high-grade sarcoma involves the combination of surgery and radiation for local control. Small, less than 5 centimeters, superficial to high-grade and low-grade tumor can be treated with excision alone. Here, same patient where was in left thigh tumor, a post-operative image. Chemotherapy is deemed to be essential part of the standard treatment of mainly bone carcinoma, Ewing sarcoma, and osteosarcoma. But routine use in a soft tissue sarcoma remain largely unproven. As a result, our 20 patients, 14% of soft tissue sarcoma, 2 were bony sarcoma, 4 were visceral organ sarcoma. Out of 14 sarcoma patient, 10 patients are male and 4 patients are female. And the male is to female ratio is 2.5 is to 1. Out of soft tissue sarcoma, 7 were liposarcoma, 3 were malignant fibrous histiocytoma, 1 were spindle cell sarcoma, 2 were fibroma, 1 is liposarcoma on histopathological examination. As the sex distribution of male is to female, type of sarcoma may live up to 50% is liposarcoma, one in our study. There is a site of sarcoma, and about extremity, about 57% of cases in extremity, in retroperineum 14%, and trunk is 20%. Age distribution, liposarcoma only 40 to 50%.
30 seconds left. Be fast, Krishna.
Yes. A conclusion: the soft tissue sarcoma are a rare aggressive malignant tumor of the soft tissue tumors. Size, depth, grade, and presence of metastasis determine the patient outcome. The most common site of occurrence in the extremities. The extremity is more common in lower extremity, and most common site is thigh. The treatment is complex, involving surgery and radiation. Most of patients require chemotherapy. These are your references. Thank you.
Thank you.
Thank you.
Now the judges are open to questions.
Dr. Krishan,
yes, sir.
Where you get most common spindle cell tumors? Where you get this tumor most commonly?
Sir, most commonly, sir, in muscle, sir, axial muscle.
Trunk, upper trunk, where we get this, and why we call it spindle cell?
Because in histopathologically, muscles fiber are there, so.
Yeah, it appears like spindle. Muscle fibers appears spindle in histopathology. Thank you.
Any more questions from the judges?
Okay, thank you from my side.
Okay. So now we are moving on. Thank you, Dr. Krishna.
Hello, Dr. Krishan.
Yes, sir.
Yes,
just last minute question. One question to you: which is the best modality of investigation for staging of sarcoma?
Sir, staging for in imaging
MRI or CT?
MRI, sir. Base station for MRI.
And why?
In this, there is to determine the resectability and resectability and extent of tumor, because in soft tissue sarcoma they are pseudo capsule formation. They spread deep in below the plane. So soft tissue for determination of the soft tissue is based. In visceral,
yes,
sir, in visceral, the CT contrast enhanced CT scan is for best assessment in imaging is modality.
and for tissue diagnosis, true cut biopsy or excision biopsy?
Sir, true cut biopsy is the modality of the choice. If fail, then go to excisional biopsy.
True cut biopsy is inconclusive.
Then sir, excisional biopsy. Incisional biopsy.
Or incisional biopsy. Which biopsy?
Incisional biopsy.
Incisional. It does not depend on the size of the tumor. If the tumor size is less than 3 centimeters, then you should go for excisional biopsy. More than 3 centimeters. Is there any relation with size of the soft tissue?
Yes, sir. Yes, sir. If a small tumor less than 5 centimeters, then go for incisional biopsy. Then goes more than 5 centimeters. If first go to imaging and tissue diagnosis, then go for operation.
What is the advantage of incisional or excisional biopsy? Then the true cut biopsy.
Sir, in true cut biopsy, sir, there plan of tumor and exactly not seen here. The margin for excisional biopsy, incisional biopsy for margin is clear for this.
No. For grading of the tumor, you can grade the tumor, well differentiated, poorly differentiated, and so grade of tumor. For that is you have to go for the tissue, and you have to take the bit of tissue.
Thank you, judges. Now we are running short of time. I will have to stop all the judges for the question and answer session. And now we move on to our next presentation. Dr. Arvind will be presenting. Arvind, are you ready?
Yes, ma'am.
Yes, you open your PPT and start your share screen. Yes. Yes, start.
Can I start?
Yes, start.
Good morning, everyone. My topic is on observation on the morbidity and mortality from lower respiratory tract infections following emergency laparotomy in a tertiary care center from RIMS Ranchi. Introduction. Post-operative cardiopulmonary complications are a major concern to the surgeons as well as the patients, which causes delayed recovery and prolonged hospital stay. Changes to the respiratory system occurs immediately on the induction of general anesthesia. Respiratory drive and muscle functions get altered. Lung volumes gets reduced and atelectasis can develop in more than 75% of the patients receiving neuromuscular blockers. Upper abdominal surgery alters postoperative pulmonary functions such as reduction in the total lung capacity, vital capacity, and tidal volume. It also reduces the efficiency of efforts to cough out the secretions for as long as 1 week. The respiratory system normally takes around 6 weeks to return to its preoperative state after general anesthesia. Pathophysiology leading to postoperative pulmonary complications. The respiratory effects of GA, as soon as the patient undergoes loss of consciousness, it begins. Central respiratory drive is depressed, causing prolonged apnea, followed by a return of spontaneous ventilation with a dose-dependent reduction in minute ventilation. The ventilatory responses to hypercapnia and hypoxia are significantly impaired even at low doses of anesthetic drugs. There is a reduction of functional residual capacity of around 15 to 20%, irrespective of whether the patient has not received neuromuscular blocking drugs. Post-operatively, hypoxia is common due to airway obstruction, continued sedation of residual anesthetic drugs, neuromuscular blocking agents, and impairment of ventilatory responses to hypercapnia and hypoxia. Aims and objectives. The aim is to understand the risk factors leading to pulmonary complications post-laparotomy, such as age of the patient, personal risk factors like smoking, occupation, time delay between the onset of illness to the point of intervention, that is including immobilization from the starting of the illness, comorbidities like diabetes, hypertension, asthma, tuberculosis, preoperative chest abnormalities like bronchiectasis, consolidation, infections of the chest, type and duration of the surgery, use of in-situ spirometry and mobilization after surgery. The outcome is mainly on the duration of hospital stay. Materials and methods. This is an observational study. Type of the patients included from the emergency department requiring emergency laparotomy. Period of study was from April 2019 to August 2020. It was done in the Department of General Surgery. Rajendra Institute of Medical Science, Ranchi. Cases were 34 patients who developed post-operative pulmonary complications based on the chest findings and the chest X-ray changes. And in the study, COVID-19 positive patients are also included. Controls are selected randomly from the rest who did not develop post-pulmonary complications. In this, the upper abdominal surgeries were gastric and duodenal perforations, blunt trauma causing splenic injury, and other solid organ injuries. Lower abdominal surgeries were like small bowel perforation, small bowel gangrene, small bowel stricture band adhesions, irreducible incisional hernia, and obstructed or irreducible inguinal hernia. These are some of the X-ray changes post-operatively in which who got post-op pulmonary complications in COVID-19 patients. Results: the incidence of postoperative pulmonary complications in the study was 7.1%, out of which 82% occurred in the upper abdominal surgeries compared to 18% in the lower abdominal surgeries. Of these, elderly people and smokers had a higher incidence among them. The average hospital stay in these patients was 15.4 days compared to 8.9 days in controls. They were treated with spirometry, breathing exercise, mobilization, steroids, bronchodilators, and sometimes therapeutic pleural tapping was done. Mortality rate was 12% in postoperative pulmonary complication in cases, and in COVID-19 patients it was 0. Conclusion: factors like increased age, smoking, delayed presentation, prolonged duration of surgery, incision length, post-operative use of opioids, and other complications which make the patient bedridden, such as the burst abdomen, have led to the onset of pulmonary complications such as atelectasis, pleural effusion, chest infections, pneumonia, and ARDS. These are not totally avoidable complications, but the severity and morbidity associated with it can be reduced if it was identified earlier, treated appropriately, and thereby reducing the hospital stay. In this study, the chest physiotherapy and early mobilization have been found to reduce the incidence of PPCs. Despite recent advances in intraoperative and postoperative management, it is still a major cause of morbidity and mortality following laparotomy, especially upper abdominal surgery. Thank you.
Thank you, Dr. Arvind. Now judges are open to questions.
Dr. Arvind, did you have any exclusion criteria in your study group?
Sir?
Did you have any exclusion criteria?
Pediatric population was not included in this criteria groups.
Okay, Arvind, why there is more pulmonary complication in cases of upper abdomen surgeries?
Sir, upper abdominal muscles are one of the accessory muscles involved in respiration. So if after surgery, these muscles get exhausted or not return to full normal function, and it causes delay in recovery, sir.
Because of pain, patient stops using those muscles. That causes upper respiratory tract infection in those cases, or lower respiratory tract. Okay.
Yes, sir.
Thank you.
Thank you.
Dr. Arvind, it was a nice presentation. What are the measures taken to prevent the respiratory tract infections after the abdominal surgeries?
Early mobilization of the patient, chest physiotherapy, and asking the patient to cough out the retained secretions in the chest or in the oropharynx, and spirometry should be initiated as soon as possible, sir.
Okay. Thank you.
Thank you, sir.
Okay, thank you, judges. Thank you, Dr. Arvind.
Thank you, ma'am.
Now I move on to our next presenter, Dr. Mahesh.
Good morning, everyone. Today's my topic is effect of adding interrupted sutures to continuous closure of laparotomy in decreasing wound adhesions in emergency laparotomy. Background: surgeons who perform the emergency laparotomy have a number of decisions to make regarding abdominal closure. Surgeons can choose to close the incision in anatomical layers or mass, as well as using either the continuous or interrupted suture technique, of which there are different styles of each. There is ongoing debate as to which suturing technique and suture materials are best for achieving definitive wound closure while minimizing the risk of short and long-term complications. Introduction. Major complication associated with closure of midline laparotomy is the wound adhesions, which is the early complication, which is the major cause of post-operative morbidity. It will cause a major psychological blow to the patient and to the operating surgeon. The prevalence of burst abdomen has varies from 1 to 2%. Indian authors reported burst abdomen to occur in 10% to 30% of emergency cases, which increases the length of stay and cost of treatment to the patients. Emergency patients with peritonitis often have multiple risk factors for wound adhesions. When it compares to elective patients who are nutritionally adequate and well prepared for surgery, comparatively they have less wound adhesions. The average post-operative day of adhesions is about 7th day, but may occur from 1 to 20 days, with 90% of all cases presenting before 15th post-operative day. Continuous sutures may loosen and cut through if tension on the sutures increases. Interrupted reinforcement suture technique overcomes the problem of loosening of continuous suture in case of cut through of continuous suture. Aim of the study was to compare wound adhesions between patients who underwent two different suture techniques of rectus sheath closure. Because the proposed study was conducted in the Department of General Surgery, TMH, Jamshedpur, for a period of 1 year from September 2019 to September 2020. A total of 50 patients who were taken in the study. All the patients who were taken up for emergency laparotomy, fulfilling the inclusion criteria, are divided into two groups, that is Group A and Group B. Alternate patients was allocated to Group A and Group B, which contained 25 patients of each. Group A patients underwent continuous method of abdominal fascial closure. Group B patients underwent interrupted reinforcement method of abdominal closure. And the inclusion criteria and the exclusion criteria. 18 inclusion criteria is 18 years age group and above, and all the patients presenting to emergency department needing emergency laparotomy. And the exclusion criteria is patients under the age of 18 years, patients with incisional hernias, and patients with burst abdomen presentation, patients with comorbid conditions like renal and hepatic failure, malignancy, patients on chemotherapy and radiotherapy, and collagen vascular disease. Method of closure. First, we placed the interrupted sutures with a large bite taken with PDS number 1 on the cut edge of the linea alba from outside in 2 centimeters from the edge. The needle emerged on the other side from inside out at the same level. On average, 4 such interrupted sutures taken with say 3 centimeters apart and left in place untied until continuous closure done. Continuous closure was done using Prolene number 1 loop suture, with care being taken to place each bite 1.5 centimeter from linea alba edge and successive bites being 1 centimeter from each other. The edges of the linea alba was gently approximated without strangulation, with an attempt to keep the suture to wound length ratio of 4:1. This is the intro picture of how we took the interrupted sutures. We first placed the interrupted suture, we left it untied, and we completed the closures, continuous sutures. Then we tied over it. And the mean age in Group A is 38.2 and Group B is 42.6. The percentage of male patients in Group A is 76%, Group B is 84%. Female patients in Group A is 24%, Group B is 16%. Mean length of incision in Group A is 18.24 centimeters, Group B is 19.16 centimeters. And duration of hospital stay is 11 days for continuous suture and 9 days for interrupted reinforcement patients. Most common diagnosis was hollow viscous injury with peritonitis. Patients who were diagnosed to have acute peritonitis on basis of history, clinical examination, and relevant investigations. Informed consent was taken from all patients. Demographic data was recorded. Mean closure time. Mean closure time for continuous closure is a bit less time required, which is 20 minutes. And for interrupted reinforcement, we need it take 23 minutes to close the abdomen, and the difference was found to be statistically significant. And in the results, Group A, Group B, we observed 1 partial wound adhesions in Group A and 2 complete wound adhesions in Group A, and there is only 1 partial wound adhesions in Group B patients. And the risk factors in our study patients are the 64% patients have diabetes, and 42% have intraperitoneal sepsis. 16% have anemia, 20% have abdominal distension postoperatively, and 50% patients have hypoproteinemia, and 26 patients developed postoperative respiratory complications, and 16% patients will develop wound infection. Discussion. The ideal method must maintain tensile strength throughout the healing process with good tissue approximation. It does not promote wound infection, is well tolerated by the patient, and is technically simple. There is no optimal technique to close abdominal fascia, especially in emergency settings. Complete wound adhesions is a very serious postoperative complication associated with high morbidity and mortality. 2 factors must be considered. One is the intra-abdominal pressure, and second is the wound. Intra-abdominal pressure the change in intra-abdominal pressure contributes to so many factors, certainly which is not in surgeon's control. But the second factor, the wound is sufficient to withstand the pressure changes. And the strength of the wound depends on the healing of the tissues, cohesion of the healing tissues, and the suture material which we used, and the bandage and regular sterile wound dressings, and the protein calorie malnutrition. This protein calorie malnutrition is widely prevalent in Indian population, and many patients undergoing emergency laparotomy suffer from one of the comorbid conditions detrimental to healing, like anemia, poor nutritional status, postoperative pulmonary complications, and hemodynamic instability. Why interrupted reinforcement? Provides additional support and disperses the tension more evenly over the entire wound, minimizes the loosening of the entire continuous sutures if cut through occurred at one place, and require less time and simple to place sutures compared with interrupted closure technique. By using slowly absorbable monofilament sutures, reduces the other late complications associated. And the conclusion of the study is, our study is that continuous method reinforced with interrupted sutures method rectus sheet closure is better than simple continuous suture in terms of wound adhesions. And these are my references. Thank you.
Thank you, Dr. Mahesh.
Hello.
Yes, sir.
When you visit your ward in a patient operated 7-8 days ago, and what is the first sign you see for wound adhesions?
So, discharge from the wound.
Which type of discharge you see?
Sir, we'll see the thick discharge. If the patient had a intraperitoneal sepsis, will be the
no sepsis exactly. This is in normal cases also. If you'll see serosanguinous discharge in a patient
on the 5th day
or 7th day, you'll know this is wound day. It's about to occur. Thank you.
Mahesh, a very nice presentation, excellent presentation. Just one question to you: what are the ideal suture materials for closure of the abdomen? What should be the
non-absorbable monofilament suture, sir?
And what are the ideal characteristics of suture materials? What should be the features of the ideal suture materials?
Sir, for continuous closure, sir, we should do the synthetic monofilament non-absorbable suture.
What you are using here?
Number one, for continuous used proline number 1 suture, sir. For the interrupted, we used PDS 1, sir, because PDS is a slowly absorbing suture, sir. In the late post-operative period, if we used a non-absorbable suture, it will leads to there is a chance of developing fistulous tract post-operatively. With the absorbable sutures, we can minimize this complication in long term. And for using monofilaments,
proline is a absorbable or non-absorbable?
Proline is a non-absorbable, sir.
That is, you are telling absorbable.
PDS, sir.
Okay.
We should PDS data, sir. PDS ka value.
Okay.
So
what is the tensile strength?
Sir.
Dr. Mahesh, you have endorsed what I have told earlier in the case of Dr. Chandan, which the presentation was somewhat similar. It's a good presentation. Can you say, is there any use of abdominal binders in the post-operative period? Abdominal belts and all?
Yes, sir. During initial post-operative period, there is some use, sir. Because, sir, during post-operative period, sir, we encourage the patient to mobilize. So, mobilization, there is a physical application, sir, called hack and saw effect, which states that there are certain tension forces that occur at the suture line. In case of continuous sutures, when we mobilize the patient and when patient uses his abdominal muscles to respire or to make a move, interrupted reinforcements or and abdominal binders will decreases those forces on the main suture wound, so that the cut through effect will minimize. There is some added effect to prevent the wound adhesion, sir.
Okay. Thank you.
Okay, thank you, Dr. Mahesh.
Thank you, sir. Thank you, ma'am.
Now we move on and call upon our next speaker, Dr. Naveen. Yes.
Yes, ma'am.
Okay. Yes, Dr. Naveen, you can start now.
Yes, sir. Good morning, everyone. Good morning, sir. Myself, Dr. Naveen Kumar Shah, GRS 3. My guide is Dr. Professor Mrityunjay Sarawagi. My topic for paper presentation is study on presentation and behavior of colorectal carcinoma in Jharkhand. Introduction: colorectal carcinoma is formidable health problem worldwide. In the world, colorectal cancer is second most common cancer in women and third most common in men after lung and prostate cancer. The annual incidence rate in colorectal cancer in male is 4.4 to 4.1 per lakh. In annual incidence for colon cancer in female is 3.9 per lakh. Colon cancer is 8th most common and rectal cancer is 9th most common among the men. For women, rectal cancer is not included top 10 common cancer, while colon cancer is 9th most common cancer. In fact, 5.7% of patients with newly diagnosed colorectal cancer are under 45 years of age, and 20.5% are younger than 55 years of age. For individuals under the age of 50 years, the incidence of colorectal cancer rose by 22% from 2000 to 2013, most accounted by the tumors of distal colon and rectum. Incidence strongly varies globally and is closely linked to the element of so-called Western lifestyle. Incidence is higher in men than women and it strongly engages with age. Recent UK data reports a delay in 10 months between the onset of symptoms and treatment of colorectal carcinoma, with a median delay of 3 months, usually because the patient does not think the symptoms are serious. Colorectal carcinoma contributes to significant morbidity and mortality. Rates are reported to be on the increasing the low resource settings. However, colorectal carcinoma has a good prognosis when managed well in the early stages, with a 5-year survival rate of 90%. Aims and objectives: the aim of this study to note different presentation and age variation of colorectal carcinoma for patients and its method of diagnosis and management, to reduce the mortality and morbidity of disease by diagnosis at early stage, and to diagnose the colorectal carcinoma at early stage so that medical care can possible as early as possible. Material method: source of data: patient of colorectal carcinoma admitted Department of Surgery, RIMS Ranchi. Type of study: observational study. Period of study: 1.5 years. Place of study: indoor patients in Department of Surgery, RIMS Ranchi. 25 cases. Sample size: 25 cases of colorectal carcinoma. Plan for analyzing data: patient come with a complaint of bleeding for rectum, ulceration, bowel habit, rectal pain, rectal discharge, abdominal pain and abdominal distension, incontinence, loss of weight, and features of intestinal obstruction and other non-specific symptoms. All general examination, peritoneal examination, digital examination were done on every patient, followed by colonoscopy or colonoscopy rectal biopsy, followed by CT or colorectal. Some patients presented with acute intestinal obstruction were operated and colonic mass was found. Pre and post-operative serum CA level was done on every patient. Discussion: a number of environmental and genetic factors have been identified for colorectal cancer. These include age, nutrition, low physical activity, inflammatory bowel disease, and genetic factors. It is estimated that 80% of all cases of colorectal carcinoma can be caused by the diet alone. However, heritable factors contributed to 35% of risk of developing colorectal carcinoma. Heritable factors divided into two groups: high penetration autosomal dominant syndrome and low penetration autosomal syndrome. High penetration autosomal syndrome includes FAB and HNPCC, which represent the 2 to 5% of all colorectal cancer associated with 80% of lifetime risk. Proximal diseases presented with the iron deficiency anemia, microcytic hypochromic, and abdominal mass, or as an emergency presentation with sign and symptom of intestinal obstruction. However, the left colon and the rectal cancer, the presentation is usually with the rectal bleed and change in bowel habit, which is usually increased in frequency of defecation and or low stool. Rectal bleed occurs without any anal symptom in 60% of patients. In very low rectal cancer, the symptom of transmission is the feeling of incomplete evolution may occur. The anal pain usually indicates the invasion of anal sphincter to occur. Colonoscopy is current reference method for colorectal carcinoma and screening, recommended every 10 years in average is patient of 50 years and older. The sensitivity of colonoscopy is greater than 95%, and it can detect cancerous and pre-cancer lesions by direct visualization. This is a figure showing the rectosigmoid mass, post-operative case of rectosigmoid mass. A CT is showing the mass on rectosigmoid junction. Result: the study of the result in this present study, 25 cases were included. having age group of 20 to 70 years, out with 15 are male and 10 are female. The amounting the male-female ratio is 1.5 to 1. On the basis of age, below 40 years were 6%, below between 40 to 9%, between 1 to 60 6%, and above 60 are only 4%. On the basis of site of colorectal cancer, in young ages, most common sizes are on the distal, the rectum and rectosigmoid. On the early, in late old age patients, most common size is proximal colon. Out of 25%, 32, that is 32% patients are presented with the features of either acute institutional obstruction or subacute institutional obstruction. Most common presentation colorectal carcinoma alteration about 15%, 60%, and patient followed by the bleeding colectomy 12%, around 50%. Conclusion: there are slight male predominance in colorectal carcinoma patient in Jharkhand. Most commonly age and most common age was 40 to 50 years. There is increasing incidence of colorectal carcinoma in young adults of age less than 40 years and more common in distal colon or primary rectal cancer compared to old age. 32% of total patients presented late after the features of intestinal obstruction lead to increase in mortality and morbidity of patients. Colorectal carcinoma has a good prognosis when managed well in the early stages. To conclude, since colorectal carcinoma poses a significant burden on the community in our setting due to its late presentation, its early diagnosis and treatment is necessary to reduce the morbidity and mortality, which can be done through effective screening and an educational campaign. This must be coupled with the research into effective and age-appropriate scientific screening method for our setting, together with additional research exploring molecular etiology of this cancer and their link to the infection prevalent in the region. Thank you. These are my references.
Thank you, Dr. Naveen. You finished in time. Now I request the judges to ask questions.
Dr. Naveen, what's the role of doing a simple digital examination, a PR examination, which is the first more test to be performed?
Sir, if any rectal mass, we can examine with the digital examination.
Yeah.
Or if in colon, then if patient come with the features of intestinal obstruction, while after intestinal obstruction, then we can see the rectal for DRE for C4NA mass protruded out.
Yeah, PR examination is a must, as you might have read in Belly Love in the footnotes. If you can't put your finger, put your foot.
Yes.
All right, thank you.
Thank you.
Okay, what are the structures you remove in case of extended right hemicolectomy?
Extended right, sir, ileum, terminal ileum, cecum, ascending colon, and 2/3 of transverse colon.
Where will you stop? Extended means what?
It's, up to the up to the middle colic artery, the right branch, also involved in the right branch of middle colic artery.
Okay, thank you.
Dr. Naveen, where would you advise anterior resection and where posterior resection? AR and PR.
APR.
APR and posterior resection.
If adequate margin around 2 centimeter margin is present, then we do anterior. Posterior section.
Okay, thank you, Dr. Naveen. Thank you, judges. And now moving to our next presentation. Dr. Shubham will be presenting our next presentation. Dr. Shubham, kindly open your PPT and start screen sharing. Yes.
Good afternoon to everyone. The topic of my discussion today is a prospective comparative study between Alvarado, Ripasa, and Tagency score in diagnosing acute appendicitis. Now, the introduction, the acute appendicitis, as you know, is one of the most commonest surgical emergency and is more prevalent in the second and third decades of age and decreases with age. Apneic information is diagnosed mainly based on the clinical history and its clinical examination, along with lab investigations like increased leukocyte count and radiological assessment. For increasing the rate of accurate diagnosis of the apneic information, various methods have been tried, including ultrasonography, CT, and even radioisotope imaging along with clinical examination, but no investigation is proven to be superior. The accuracy of the diagnosis of the acute appendicitis is approximately 7 to 80%, while the error are commonly resulting in occurrence of perforation to 20% and negative appendectomy to 2 to 30%. Various scoring systems have been developed in diagnosing appendicitis. In one of the ways is Alvarado, which is most popular and most commonly used scoring system. This is based only on clinical laboratory parameters. Another one is the RIPAS score, which has been developed in RIPAS Hospital, Brunei, which is helps in diagnosing the appendicitis based on 14 clinical parameters, which includes 2 demographics, 5 clinical symptoms, and 5 clinical signs and 2 investigations, and 1 additional parameter, that is the foreign national identity card. In 2005, Jasicon and co-workers published a simplified system with 4 variables and a total score of 15 for diagnosing of the appendicitis, which is termed as the Jasicon scoring system. This is a combination of clinical evaluation, ultrasonography, and laboratory marker of inflammatory response. The parameters we use in Alvarado, every score is been given 1 point except leukocytosis and tenderness in right lower quadrant, which gives a scoring of 2, and a score of minimum 7 is required to diagnose appendicitis and goes for surgery. While in Jasicon, there are 4 parameters, out of which 6 points is given for ultrasound finding suggestive of appendicitis, while 4 points for the presence of right lower abdomen tenderness, and a scoring of minimum 8 is required for diagnosing the appendicitis and requiring for surgery. And the RIPAS score, as already discussed, based upon 15 parameters, out of which 1 is simply given for male and age less than 13.9 years and anorexia, nausea, vomiting, while 2 points are scored for abdominal guarding and Rowinsky sign. And the total score is 16.5, while the cutoff mark for is 7.5. The aim and objective is to compare the efficacy of Alvarado, RIPAS, and Jasicon score in diagnosing the appendicitis and to reduce the negative appendectomy rate, and to evaluate the predictability of the 3 scores in the preoperative diagnosis of acute appendicitis and comparing its accuracy with the histopathological examination. Now, this is a prospective observational study. The study has been conducted in the Department of General Surgery, Tata Main Hospital, and the study population constitutes of patients who are coming with symptoms of acute appendicitis and fulfilling the inclusion criteria. Now, the inclusion criteria include the patients suspected of acute appendicitis in emergency department and OPD, aged between 4 to 60 years of age. And the exclusion criteria are the patients which are not willing for surgery, the patient with appendicular perforation, appendicular abscess or mass, not giving consent for the surgery, or living in DAMA, that is discharge against medical advice within 24 hours. So in my case study, it is divided into 2 groups. The group 1 is the persons who have performed appendicectomy has been performed, and in group 2 includes the persons who have underwent conservative management. Now this grouping has been based on the clinical judgment based on the clinical judgment. Now, from my study, showing that the appendicitis has a male predominance of 75-57% as compared to female, and the most common symptoms that and the most common age group that patient come with are within 21 to 40 years of the age. While the most common symptoms they come with is nausea, vomiting, followed by abdominal pain, and with some few cases comes with fever also. Well, most of the patient presents with the symptoms within the first day and followed by 2 to 4 days. And very rarely we see the patients who have come more than 7 days. Now, this is my scoring that I have done here in the Alvarado score with the patient. Only 11 cases have underwent appendicectomy with scoring more than 7, while in Jasicon, 15 patients have been scoring more than 8 and went for appendicectomy, while in RIPASA, it is 18% patients who have undergone appendicectomy out of 7 with scoring more than 7.5%. Now, since there are no negative appendicectomy found, so that these are all the clinical based on only appendicitis. All the histopathological examinations showed features of appendicitis, and there were no normal appendix. Now, this is my test result with Alvarado score showing a sensitivity of 64.7%. With Jasicon, it is 88.23, while RIPASA showing 100%. While the accuracy of RIPASA score is showing 95.24%, with Jasicon 80.95%, and accuracy of Alvarado is that of 57.14%. While specificity of Alvarado is maximum with 75%. Now, these are the other studies that have been comparing the different scoring systems. One in study 1 is done by Nanajudan in our KMC Manipal Karnataka in 2014, showing a sensitivity of 58.9% to Alvarado, while Ripasa scoring 96.2%. While another study too done by M. Korut et al., that is in Antalya Training Institute in Antalya, Turkey in 2020, showing a sensitivity of 68% and a Ripasa score of 97.5%. Well, another score a bit differs with my study, which is in Sikkim Manipal Institute of Medical Science in India in 2010, showing us more sensitivity to Alvarado score of 94.2%, with Ripasa score with 88%, while specificity is 70%, and that of Ripasa score is 67%. Discussion in one of a study it is conducted to detect the epidemiology of appendicitis, which among 971 cases they found that the incidence in the male is 1.3 per 1,000 versus 0.99 for males. Now, statistical analysis of the present symptoms in my study revealed that the presence of right iliac fossa pain and nausea vomiting are the predominant symptoms in the patient of acute appendicitis, and most of the patients come within the first day of the symptoms. The statistical analysis of my data revealed the reverse score is superior in diagnosing the acute appendicitis with sensitivity of 100% and with accuracy of 95.24%.
30 seconds left. Be fast, Shubham.
While Alvarado is better in excluding the acute appendicitis with specificity of 75% and predictive of 91.6%. Now, my conclusion is the implication of Alvarado, Jasicon, and Ripasa score help in diagnosing and exclusion of presence of acute appendicitis. In my ongoing study, Ripasa score a sensitivity of 100% with accuracy of 95.24%. So, in a view of accuracy, my Ripasa score is a superior scoring system as compared to other two scoring systems that will help in diagnosing the acute appendicitis and decreasing the negative appendicectomy. These are my references. Thank you.
Okay, now judges can ask questions.
Yes, Shubham.
Yes, sir.
It is a very nice presentation, excellent presentation. Is there any role of CT in cases of in diagnosis of acute appendicitis?
Sir, in some of the countries, like in developed states like America, they have introduced CT scan, but it is mostly we would need if there is some better complications, because based on clinical examinations, as my scoring as one of my scoring system, that is a Ripasa score, is totally based on clinical parameters and laboratory parameters. So we don't need to go for any radiological assessment based on, we can on clinical basis, we can go for the for the diagnosis and for the surgery of appendicectomy. CT is mostly needed if there is coming with other symptoms, that is right iliac fossa pain. It could be also due to ileocecal tuberculosis and also forming mass. It is mass in the right iliac fossa. If we see a patient coming with a mass in a right iliac fossa, then instead of clinical parameters, we should go for a CT scan to rule out the ileocecal tuberculosis or mass in the right colon. For that, we need to rule out. For that, we should go for a CT scan.
Is there any role of diagnostic lab for acute appendicitis?
Diagnostic lab, sir, I don't think so, sir. It is needed because in my institute, mostly we go through the clinical parameters, and one or most we should, in some few cases, to that we go for to clarify it, we go through ultrasound only. Diagnostic lab is rarely done in my institute.
Especially in young female.
Yes, sir. Young female, yes, sir. In young female, we can go for that.
Okay.
Dr. Shubham, what do you do if an appendicular lump has formed?
Yes, sir. Thank you for the question, sir. Sir, if appendicular lump has formed, then we will first plan for the conservative management and we should wait for 4 to 6 weeks and then plan an interval appendicectomy. If the patient shows symptoms like generalized tenderness, signs of peritonitis or sepsis with tachycardia, then we should immediately go for exploratory laparotomy, rule out the pus collection, drain it. If possible, if we see the appendix, then try to do a partial appendicectomy if possible. Then we will test the drain and then we'll make a post-op observation. Keep under a post-op.
Okay, thank you, judges, and thank you, Dr. Shubham. We are running out of time, and so I call upon our next presenter, Dr. Syed Sharik. Yes, Dr. Sharik.
Yes, ma'am. Yes, ma'am.
Open your PPT and start your presentation. Start screen share. Yes. Start your presentation.
Yes, ma'am. Hello. Good afternoon, all the judges, sir. Myself, Dr. Syed Mohammad Sharik. I am junior resident, third year in RIMS Ranchi, Department of General Surgery. And my guide is Professor Dr. Mrityunjay Sarhogi, sir, who is also a unit head. And my topic of today's presentation is role of early re-exploration in enterocutaneous fistula and its effect in overall survival of patient in tertiary center of Jharkhand, RIMS Ranchi. In introduction, we all know enterocutaneous fistula is an abnormal connection between an intra-abdominal gastrointestinal tract, and that can be classified by anatomy, etiology, or physiologically. Cause of majority of enterocutaneous fistula are post-operative, 85 to 95%, while spontaneous cause of fistula are between 5 to 15%. We also classify it by the volume of its output, like high output fistula, low output fistula. It is very disheartening for us because it is like very challenging to manage once the enterocutaneous fistula is formed. Our goals of management is the restoration of gastrointestinal continuity and allowance of internal nutrition with minimal morbidity and mortality. So a multidisciplinary approach is essential to the successful management, either by operative or non-operative means. And of course, my topic is with meticulous surgical technique and with a fair decision to when to operate and when not to operate. This presentation emphasizes early surgery to control sepsis and to start early enteral feeding to decrease overall mortality and morbidity. My method was observational case series analysis study in the Department of General Surgery, RIMS Ranchi. I included 40 patients of age group between 50 to 65, in which majority of patients were in third and fourth decade, with a sex ratio of male to female was 5:3. Here, as can I put it in a chart, detection of fistula we did in less than or equal to in 7th day out of 40 in 25 patients. 8 to 15th day we detected the fistula in 13 patients, and after or equal to 16th day we detected in 2 patients. And in this pie chart, site of enterocutaneous fistula is I have shown, where ileum was most common site with 13 patient. In jejunum there was 10 patient, duodenum 4 patient. Site of ECF was cecum in 6 patient, hepatic flexor 1, transverse colon 2, and sigmoid was 4. As we dealt with the ECF, patient came to us outside from RIMS where primary operation was done. 25 patient was like that, and 15 patient was in our RIMS where we operated and enterocutaneous fistula occurred. And our motive was to deal with the patient with ECF with sepsis, where we had 34 patient who had enterocutaneous fistula with sepsis and 6 patient enterocutaneous fistula with non-sepsis, aseptic condition. Here I have described in chart in high output and low output. Out of 40 patients, 16 patient was having high output fistula and 24 patient having low output fistula. And this fistulochlysis graph is showing the management part. I will discuss it later. There is some patient of enterocutaneous fistula as we dealt with here. Now the treatment part, or I would say management part. Once we suspect the enterocutaneous fistula has happened, we go for general supportive care to stabilize patient, fluid replacement therapy, crystalloid colloid solution. If the patient can afford, we should give him or her TPN for at least 4-5 days, in which we have discovered the better outcome. Blood transfusion. After initial resuscitation, septic complications need to be controlled with proper antibiotics, propranolol, octreotide, loperamide. We also study about codeine phosphate. If the patient is
hello, hello,
hello,
I am visible. I am audible there. Hello.
Yes, sir, you are audible there.
Sumega, please stop the functioning in Hall B. We are going to start the AGM. So
Okay,
please
sir.
join the AGM. Hello.
Okay, sir.
Dr. Sumega,
should I
continue? Yes, sir, yes,
please
sir.
stop B.
Okay. Okay. So, Dr. Sharik, you just be there here only.
Yes, ma'am.
Just complete it.
We will
Just complete
resume
it first.
after the AGM. Okay.
Complete it first.
Okay, ma'am. Should I continue?
Yes, sir.
Uday, sir, should
Yes,
we
sir,
complete?
I have asked Sumega to stop it. She is asking for 2 minutes.
So, should we complete this presentation, sir? Okay, Sharik, just continue then.
Okay, ma'am.
In 2 minutes are only left. You have only 2 minutes left now. Okay.
Yes, ma'am.
Dr. Sumega, please stop. Dr. Sumega, please stop. We will resume after the GB.
Okay, okay. Then just be here. Okay,
ma'am.
sir.
I'm continuing.
No, don't continue now.
Whatever
Just stop
whatever
there.
is left will be covered up later on.
Okay,
Okay.
sir.
And join, ask the all audiences who are general body, who are life member to join Hall A.
Yes, sir. Please, all judges also, please join Hall A. We are living here only. And we will resume after the meeting.
Regular members, all the regular member can join.
Yes, sir. Yes, sir.
No associate and no non-member. Okay.
Which hall?
Hall A. Join
Hall A.
Hall A.
Send the link on Hall B. So everybody just join in from there.
Okay.
I have sent the link to Hall B on the chat box so they can directly join from there and come to this hall.
Ajad, you can start. Ajad, you can start. Hall B has stopped. Hall B is stopped.
The link has been sent on the chat box. Please, you can just directly use that link to join in. Sumegha, are you there?
Good afternoon, everybody. We are going to start.
Azad, you are not visible. Azad, you are not visible. Yes. Yes. Azad, start the proceedings. Azad, please start the
Sumegha, are you there?
proceedings.
Sumegha? Sumegha? Can I just request everybody to join in? I have sent the link.
Yes, sir. Azad. Yeah. I, as a chairperson, ASI Jharkhand chapter, welcome you all in the annual general body meeting on this virtual platform. This whole year was the worst in relation to the association activity. I can blame the pandemic, but no, I take the responsibility of my inactivity, my vision gone in vain. On achievement, I could have added to my tenure this marvelous virtual Jasicon, but I failed to do so. I am very much thankful to Dr. Arunima and Dr. Sunil, who organized this conference in such an appreciable way that everyone will remember in year to come. They will took my responsibility on their shoulder. I am having no hesitation in saying that this Jasicon is, of course, having banner of ASI, but fully owned by Dr. Arunima in association with Dr. Sunil. This makes me confident that association is in coming year going in hand of more efficient and dynamic chairperson who has shown trailer of her vision in running Jasicon. Coming to association, I should point few things which I failed to govern in my tenure. Till last, I fail to understand that the website of Jharkhand ASI belongs to association or organizing committee. Unfortunately, so many things I, along with you all, knew through the web. There was a well-established proceeding that present chairman, secretary, immediate past chairman, and our chapter glory past president ASI from our state, Dr. R.P. Srivastava, and Dr. GC member from our state, were having the direct access to state conference without registration, but I failed to do that due to technicality. I was well formulated that except guest faculty, all other presenting or participating must have ASI membership from Jharkhand. This we are supposed to boost the membership from our state. The list of my inefficiency is too long, and I humbly request my successor to stick on the proceedings. As the time is short, I conclude and welcome you all again in your general body meeting. Thank you. Sir, Azad.
Our next agenda is condolence.
Regarding condolence, I have only one name of Professor G. Das for this year. If any other name in any member, in memory of any member, please let us know. I have a name of Professor G. Das only. Yeah. Yeah. We should stand up for 1 minute.
Yes. The Dr. G. has been combined. 1 minute. Yes. 1 minute.
Thank you. Thank you all. Now next. Azad, next. Dr. Azad.
Azad, okay, thank you. Thank you. We are not talking about doctors because that is time. And exchanging the 2020. I have circulated
There is some.
Yes, people have to the annual report.
Azad.
हम लोग उनके और उससे परिवार के साथ जुड़े हैं ये हम लोगों की ड्यूटी होगी और हम लोग respectfully all going to our head to him let us pay our respect to him.
Thank you, sir. Dr. Azad. Dr. Azad, please proceed.
I have nothing to say. Just I want to say something on your I think I have seen it.
Secretary report has been circulated in WhatsApp to everybody, and if anybody is having to say something, please point. Agreed?
Hello.
Nishit, Pankaj, agreed?
Yes, sir. Yes, sir. Agreed, sir.
Okay. Then proceed further. Proceed further, Hajar.
Next, the confirmation of minutes of DPM let RIMS.
Yeah.
I second it. Okay, thank you. Next agenda is matters arising out of the minutes. Matters arising out of the minutes. Hello.
If any point anyone has to raise, yeah, sir. Sir, please.
One matter is that we need to be more dynamic. We need to be more quality, and let's do our detail. Each and everyone is responsible, and everyone is very done. So let's be cohesive and take the chapter to the bigger height.
Okay, sir. Thank you, sir. We all agree with your suggestions.
Yes, we are all agree.
Next. Ajad, next.
Next agenda.
Dr. Ajad, next. I think he is having some. Yes, sir.
Hello. ट्रेजरर रिपोर्ट है. हेलो सर. तो इसमें ज्यादा कुछ इस बार एक्टिविटी नहीं है. हम ही प्रेजेंट कर दे रहे हैं ट्रेजरर रिपोर्ट, है ना?
या
वो ₹10,000 जमा किया गया है वेबसाइट के लिए. हेलो. और ₹5,000 दिया गया है. ₹5,000 दिया गया है सीए को ऑडिटेड रिपोर्ट के लिए. बहुत दिन से उनका ड्यूज था. और एक नया मेंबर ज्वाइन किया है, उसका 11,800 हेडक्वार्टर को भेज दिया गया है. डॉक्टर चंद्र प्रकाश, वो जो न्यूरो के हेड है रिम्स में, उनका लड़का डॉक्टर चंद्र प्रकाश, उसका एसोसिएट लाइफ के लिए मेंबरशिप का पैसा भेज दिया गया. यही 3 रिपोर्ट है ट्रेजरर्स के लिए.
फाइनल बैलेंस अगर you say.
So shall we start, sir?
You can start. Okay. Sharik is presenting, na?
Sharik,
okay.
Yes, sir. I was presenting.
You just share your screen.
Hello, should I start, ma'am?
नहीं वो just ये सब पार कर. हाँ, just resume from where you left.
You remember your things?
Yes, sir.
Last few slides.
Yes, sir. So I was in treatment part. I was in result part, sir.
You will have to complete in 2 minutes, okay?
Yes, sir. As I discussed earlier in my slides, I'm discussing intracutaneous fistula with sepsis. So we dealt with 40 patients, out of which in 25 patients with sepsis, there was 34%, 34 patient they had sepsis and 6 patient who had aseptic condition. In 34, we went with early surgery in 25 patient, where we noted the mortality rate of 16%, and 9 patient in whom we went with the late surgery or conservative management, we saw the mortality rate of 15% to 55%. So in discussion, even though source control may be achieved by non-surgical means, that prompt or immediate operative intervention upon fistula development has better outcome in terms of morbidity. Careful planning, meticulous dissection, resection of bowel, reanastomosis, and reconstruction of abdominal wall are critical. In my conclusion, early surgery results in decreased mortality in comparison to conservative management, and early surgery expedites the provision for enteral nutrition, faster recovery, and early weaning from TPN. These are my references. Thank you, sir.
Okay, thank you, Dr. Sharik. And now judges are open for questions.
What are the complications you get? Hello.
Yes, sir. Hello.
Sharik, what are the complications you get?
Yes, sir. Complications.
Upper GI fistula.
Upper GI fistula.
In upper GI
sir,
fistulas.
Yes, sir. Mostly they are high output fistula. So we deal with skin excoriation, electrolytic imbalance, patient losing weight.
Thank you.
Yes, sir.
Okay.
Yes, sir.
Hello.
Yes, sir.
How do you deal output fistula? How do you treat it?
Sir, pardon, sir. Please repeat the question.
How do you deal with high output fistula?
High output fistula, sir. Yes, sir. In high output fistula, we went with fluid replacement, and we did propanolol, octreotide, topiramide. These were the yes, sir. These were the medication we followed, and we went with early surgery in that patients also, and we made fistuloclysis in high output fistula. We also made the fistuloclysis. And we get the better outcome in which we did the early surgery.
Okay. Okay. Thank you.
Any more questions from the judges?
Good.
Okay, no questions are
Okay,
coming.
thank you.
Okay.
Welcome, sir.
Good presentation,
Thank you, Sharik, for your presentation. And now we move on to our last presentation from Dr. Shruti Sagar.
Thank you so much, sir.
There? Please unmute yourself. Yes.
Thank you.
Yes, now Dr. Shruti Sagar, you just open your PPT and start your presentation. Start screen sharing. Yes.
Good morning, everyone. I'm Dr. Shruti Sagar, and today I'm gonna present a study about bacteriological analysis of bile in patient undergoing cholecystectomy in NMCS Sasaram. Introduction: gallstone disease is a frequently occurring disease in India, although most cases are asymptomatic, but still, gallstone disease contributes substantially to health care cost, and its complications are sometimes life-threatening. Cholecystectomy is currently a frequently performed operation for gallstone, usually Usually bile duct are sterile. However, the presence of gall
म्यूट किया वहां जज है तो सुनते जा रहे, मेरे को छूट गया, एक जज करते जा रहे। सुबह भी उसी घर से आए, नाश्ता खाना पानी करते 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 यहाँ करते करते सुनते सुनते अब घर जा रहे, घर में बैठ के देखेंगे। और तुम्हारा सब ठीक चल रहा है?
However, the presence of gallstone within
खाली ज्वाइन करा दिया ऐसे ही।
either the gallbladder in the biliary associated with bacterial colonization of the bile. Upon bile duct obstruction, bacterial proliferation within a stagnant bile while biliary pressure increases. Eventually, the bacteria presumably translocate into the circulation, causing a systemic infection. Acute cholangitis response. Acute cholangitis responds a continuous clinical spectrum and can progress from locally biliary infection to advanced diseases with sepsis and multiple organ dysfunction syndrome. Therefore, it is important to know the microbiological flora of the gallbladder. Therefore, prophylactic antibiotic are given. Prophylaxis would be appropriate according to the bacteria isolated from the bile and could prevent post-operative infection. In view of the above said, we studied the bacteriological analysis of bile in patients undergoing cholecystectomy. Aims and objective. Our aim was to evaluate the microbiological profile of patient undergoing cholecystectomy. Methodology by a prospective non-randomized descriptive study was done in 50% undergoing laparoscopic cholecystectomy at Narayan Medical College and Hospital, Sasaram between a period of 1st July to 30th June 2020. Inclusion criteria was patient of any age group undergoing cholecystectomy in NMCS Sasaram. Exclusion criteria were immunocompromised patient with antibiotic with any known source of sepsis, patient with history of ascending cholangitis, patient diagnosed with empyema of the gallbladder, and patient who had undergone ERCP or endoscopic spectrectomy within 1 week of the surgery. Procedure. Method of bile culture and antibiotic resistant testing. Bile was aspirated prior to cholecystectomy and transported to the laboratory as soon as possible. Specimen was evaluated for any organism. The bile was then incubated to see growth of any organism. Antibiotic sensitivity was also tested. A statistical analysis. The data collected was studied by statisticians and was analyzed for finding macrobiological profile of bile and cholecystectomy patient by using chi-square test. P-value was less than 0.05 and was considered significant. Result. In our study, we had the study had following observation. Among our study population, 50 patients were admitted for cholecystectomy. All were diagnosed with cholelithiasis at the time of admission. Clinically, 40% experienced pain, 18% had dyspepsia, and 3% had fever at the time of admission. 26 patients had chronic disease, 10% had diabetes mellitus, 6% has hypertension, 40% underwent laparoscopic cholecystectomy, 7% underwent open cholecystectomy, 3% 3% in which there was conversion from laparoscopic to open cholecystectomy because of the unclear anatomy. All the 3 patients had recurrent who got converted had a recurrent attack of acute cholecystitis and were admitted for acute cholecystitis only. After the evaluation of bile culture in our study of 50%, we got positive culture in 70% and 17%. Out of 50%, we got positive culture reports in 17%, that is 34% cases, we got positive culture report. Among these 34% patient. Klebsiella and Pseudomonas was the most common organism isolated, followed by E. coli. In surgical practice, discussion. Incidence of gallstone disease with the age increases with age. It is more common in women. It is more common in women. That is, male is to female ratio is 4:1. And most of these stones are, more than 50% stones are asymptomatic. Pathogenesis of gallstones are multifactorial, and infection is one of the major cause among them. Antibiotic resistance has become a major clinical and public health problem because of the overuse of the antibiotics, irrational
30
use of
seconds left, to be fast.
Okay, ma'am. The credit for the first chemical analysis of composition of gallstone was made in 1970 and 1789 by Forke. In order to prevent emergence of resistance of antimicrobial, the careful and appropriate uses of antibiotics should be done. Levy in research paper stated that there is a need to reserve precious antibiotic to protect vulnerable patients from transmission of disease agent in hospital and when they are completely recovered at home. In surgical practice, the use of antibiotic prophylaxis of elective surgery are not always indicated in cases of laparoscopic cholecystectomy, in which there is recommendation from Scott Intercollege Guideline Network that that it should not be prescribed in patient undergoing laparoscopic cholecystectomy. And the statement was various studies like Illig et al., Dobie et al., Higgins et al., and Tochi et al., Koch et al., which have compared antibiotic with no antibiotic in elective laparoscopic cholecystectomy, and all have concluded that antibiotics have no role. That is, antibiotics noted. Our aim in this study was to evaluate.
You were exceeding time, so I'm sorry to interrupt you. I already informed you about that. Your 30 seconds are left. So now judges are open to questions.
Dr. Shruti Sagar.
Yes, sir.
Sumekha, was this the last presentation?
Yes, ma'am.
Okay, fine. So I have a presentation in Hall A. So before going there, I just want to thank all my judges. Thank you very much for being so patient and judging all the papers throughout the day. Thank you very much. And we will have the results. Thank you, Bodra sir. Thank you for the whole hectic day. And we'll see you in Hall A. We are having a wonderful session of video presentation. So all of you, please join in. So Megha, please carry on. Okay.
Yes, ma'am.
Thank you.
Okay. Yes, ma'am. Judges, you may ask questions and finish the session.
Dr. Shruti,
yes, sir.
What's your take-home message for this process? What's the use of doing bacteriological analysis?
Sir, our focus was that we should not use antibiotics in cases if you are posting a case of elective laparoscopic cholecystectomy, to minimize the use of antibiotic and to reserve it for severe cases.
How do you take the sample of the bile?
Sir, in open cholecystectomy, we used by 10 ml syringe, sir, in open, and in lab.
But you are already going for cholecystectomy, so you have planned. So
no, before, sir, operating like.
Okay.
How you'll get? How you'll get bile in that case?
Most maximum are like have negative culture in had. Out of 50% in our study, 17% have positive, and most of them were positive for E. coli and Pseudomonas, followed by Klebsiella and Pseudomonas, followed by E. coli.
Okay.
Oh, stop.
Any more questions?
It's all right.
All right.
Okay, I thank all the judges. Thank you so much.
Yeah, so we'll give the marks to you, Dr. Sumedha.
Yes, sir. I will make the final and I will total all the marks. You just send me on WhatsApp, sir.
Okay, we'll take
Yeah,
a picture
the
and
certificate for the judges. I will send you all separately.
Okay. Thank you. Thank you, Shubha.
Thank you. Thanks a lot, Sumedha.
Yeah,
So much, sir.
I will send it to the Arunima's WhatsApp because I don't have your WhatsApp number.
Okay,
Sir. Because yesterday you called me, that number doesn't have a WhatsApp access.
Yes, sir. That doesn't have, but
So I will send it to the Arunima. I will send it to the Arunima's WhatsApp. You just collect it from her.
Okay, sir.
Okay.
Now here we end the session, today's session in Hall B, and those who want to, you can join Hall A. Thank you so much, judges, once again for giving so much time.
And then you reconfirm by your image, maybe a CR or a H.
And now we can join Hall A if you want. And sir, I request all the judges to send your marks to me. Thank you, sir.
Okay. Out of 10 we'll give. Okay.
Okay, sir.
Sure. Thank you.